morning, respected dignitaries, esteemed faculty, and dear colleagues. Welcome to EFIGS, where experience meets innovation and where the art and science of endoscopy come together to redefine modern surgical practice. In today's era, endoscopy is not just a tool, but an extension of a surgeon's vision, enabling precision, minimizing invasiveness, and transforming patient care. Over the next few days, we are privileged to learn from some of the finest minds in the country, making this not just a program but a truly enriching academic journey. On behalf of the organizing team, I extend a warm welcome to each one of you.
So let's start with the first session. It's my great honor to introduce the first chairperson of the today's proceeding, Dr. Vijay Borkaukar sir. Sir is a chief surgeon, endoscopist and director at Krupamai Hospital, Aurangabad, with remarkable legacy of innovation and excellence. With such groundbreaking contribution to the future of endoscopy, I would like him to proceed to the podium.
It is my pleasure to introduce our next chairperson for the session, Dr. Manoj Kumar Sethi sir. With his extensive expertise in general and laparoscopic surgeries, including endoscopy and colonoscopy, he brings a wealth of clinical expertise and academic insight. We are honored to have him with us today. May I now invite him to kindly take the stage.
It's my pleasure to introduce our first speaker, Dr. Arko Pravanath sir. He completed his MBBS and MS in General Surgery from West Bengal University of Health Sciences. He is currently practicing at SKAK Sanjeevani Hospital, where he specializes in both general and laparoscopic surgery. His expertise spans diagnostic and interventional laparoscopy, along with endoscopy and colonoscopy, reflecting his comprehensive approach to modern surgical care. We are delighted to have him with us today. May I invite him now to kindly take the stage for the topic, Foreign Body in Upper GI, a Role of Endoscopy.
Hello. Good morning to my dear colleagues, respect to my seniors, and we're going to start off today's session with an intriguing topic, something that I believe will pique your interest because in our endoscopic career, we will come across these situations at one point or another. So let's get to the slide. This is my today's topic, that is role of endoscopy in foreign body impaction of upper GI. I am Dr. Arko Prabhunath from Kolkata, as you heard. I'm going to talk on this for the next few minutes. Now, why we need to talk on this? Why is it worth discussion? Let's look at the global impact. About 1,500 deaths are reported due to foreign body impaction of upper GI in United States alone. Highest number of global incidents occurs in New Zealand. Highest number of deaths occurs in sub-Saharan Africa due to impaction of foreign body in upper GI. These statistics are to impress upon you the seriousness of the thing. In Europe, in European countries like Italy, Finland, Netherlands, and Iceland, the incidence of impacted foreign body in upper GI tract is quite high. In contrast, South Korea reports the lowest incidence of impacted foreign body in upper GI. When we come to India, there is no proper statistics. Most common foreign body is fish bones in coastal states, and in inland it's mostly coins, medicines, and dentures. Now the question comes, who are the most common patients to come to us with foreign body impaction in upper GI? Mostly the extremities of the age, the young people and the extremely old people. Most common is it in children. Amongst children, toddlers are the ones to have reported the most sufferers of impaction of foreign body in upper GI. After that, infants, preschoolers, and adolescents sequentially. But till date, most impacted foreign bodies has been reported in toddlers. Toddlers, by toddlers I mean like 2 to 8 years of age. Those who can move around and are very curious and put everything in their mouth, that age group. The next question comes, where? Where is the impaction most commonly occurring in the upper GI tract? Now, if we learn the anatomy of the upper GI tract, there are at least 3 constrictions. The first constriction is at 15 centimeter, corresponding to C6 vertebra. That is the cricopharyngeal constriction. Second one is at 25 centimeter, corresponding to T4 vertebra. It's a bronchoaortic constriction. And the last one at 40 centimeter, corresponding to T11 vertebra, that is a diaphragmatic constriction. Once any food bolus or foreign body passes into the stomach, there is very little chance of impaction in the stomach, in the gastric lumen itself. Again, in the pyloric part is another narrowing which can impede the stuff to move from the stomach to the small intestine. But other than that, there is very little chance of being impacted in the stomach itself. So these are the most common points of impaction of foreign body in the upper GI tract. Now what? The question comes, what? As in, what are the most common objects that are commonly impacted in the upper GI tract? That depends upon age. For young adults, these are the most common foreign bodies that get impacted, like coins, toys, batteries, marbles. In young adults, fish bones, chicken bones, meat boluses, and fruit seeds are the most common objects. In aged patients, dentures are very commonly impacted in upper GI, food boluses, medicines, etc. When? When is not when it gets impacted, when do we need to intervene? And how to intervene, whether we need to scope or to cut. That is the question that will come across, that many of us will come across. So to answer that question, we need to understand this, that 90% of the foreign bodies will pass without any issue through the upper GI tract. Only 10 to 20% needs endoscopic retrieval. Out of that, only 1% needs surgery. So it's not like every impacted foreign bodies need intervention. Most of them you can wait and watch and sequentially radiograph, and then it will automatically pass through the narrow stage into the gastric lumen. Still, we need to understand what are non-urgent, like smooth, round, foreign, non-toxic items are non-urgent, like you don't need immediate intervention. Incomplete obstruction like marbles, seeds, ball bearings, even if they get stuck, over time they will automatically pass through. Then comes urgent, non-sharp but pointed object like pencils, pins, sharp in stomach and duodenum, objects more than 6 centimeters, and magnets. Magnets are a special type of foreign body that needs urgent intervention. Then comes the emergency. Emergency intervention is needed in various cases, some criteria pertaining to the foreign body, some criteria pertaining to the patient. High-grade esophageal obstruction, disc batteries, sharp-pointed objects need to be emergently removed as an emergency. Again, if the airway is compromised, the patient is drooling, there is signs of sepsis, perforation or active bleeding, you need to intervene immediately. Then how? How as in, what do we need to do? First is to assess where the foreign body is. For that, the basic radiograph will give us a much information, whether there is actually a presence of foreign body, what is the location, the size, the configuration, and the number. Sometimes there can be more than one foreign bodies. Young adults like babies, like toddlers and preschoolers don't often give accurate histories. So radiograph is important. Even if nothing comes out in the radiograph, you cannot see the foreign body per se. These are the signs that will give you that something is impacted, like signs of obstruction, gastric distension, proximal segment, esophageal dilation, signs of perforation can be made out. More than one foreign bodies may be present. These are the steps, basic steps. I have enumerated only the basic steps of removal of foreign body. First is preparation and protection. The airway needs to be protected at all costs. If needed, intubation needs to be done. Then appropriate accessories needs to be selected. Careful visualization under the scope, object alignment and engagement. The foreign body, when we first see the foreign body, it may not be in a position to be taken out immediately. It may be impacted, it may be poking into the wall or some impacted into the wall of a esophagus or the lumen. So sometimes we need to push the foreign body from the narrow lumen of the esophagus into the wider space of the stomach. So reorient the foreign body to a safest axis, secure the grasp with suitable device. Controlled retrieval, gentle withdrawal under continuous vision. At no point the foreign body should be out of the vision of the endoscopist. And post-removal inspection. Re-examine the mucosa for injury, and then decide whether to observe or then it needs further management. Now, instrument used for foreign body retrieval. There are several devices that are commonly used. I have only enumerated like 5 or 6. First is forceps, Dormia basket, Rothnet, snares and hoods. First, let's talk about forceps. These are the common forceps. You have used forceps for biopsy also. These are the common forceps. But for retrieval of foreign bodies, we mostly use the crocodile forceps or the rat tooth forceps with a larger teeth. This is a picture of a rat tooth forceps holding on to a stent. Now there are lots of things to be said about each instrument. I'll not go to the details. I'll only enumerate the pertinent points of each instrument. These are the advantages of using a forceps. It has an interlocking serrated teeth, high pull resistance, flat hard object like coins, keys or discs can be removed by the forceps. Effective at grabbing the blunt end of the sharp object. This is a video. I don't think it's playing. Yep. This is a impacted denture. This is a Sage's video. I've taken it from the YouTube only. This is an impacted denture in a esophagus. The endoscopist will try to remove it, and subsequently you will see that it has caused significant damage to the esophageal wall. Dentures are very complicated foreign bodies. For newer endoscopists, it's preferable not to venture into removal of dentures because the shape and the size are difficult to maneuver. You see, the esophageal mucosa has been severely damaged already by the. Now they have put a like a bending guard type of thing at the tip of the scope, and they are trying to maneuver. This is a normal forceps. Now they bring in a rat tooth forceps with a better grip, and they're trying to orient the forceps according to the axis of the foreign body. Now he has got hold of the foreign body. Now he can control traction under constant visualization. He is bringing it out, and this is the denture that got impacted in the esophagus. So moving ahead, this is another instrument, the Dormia basket. Most of us has used it in our day-to-day activities. It's a bit different from the forceps, as in it has a conformation grip. It can catch hold of slippery and rounded globular objects. It is made of nitinol. It's a very tough structure. Nitinol is a very aluminum memory alloy, alloy, so it does not normally break. The size of the object becomes important. If it's very small, it slips through the basket. If it's too big, its grip is ineffective. So, and there is also an issue of impacted lock, where both the basket and the object can be wedged together in a narrow space, and that becomes a surgical emergency. This is the next device, that is a Rothnet. Rothnet can also be used for slippery, rounded, soft objects, that is food boluses that are commonly impacted in the upper GI system. It gives you high visibility. You can see how the foreign body is acting, how the axis is turning and moving. Minimum drop rate prevents foreign body from slipping into the trachea from cricopharynx. That is the most important advantage of this. You don't want the foreign body to slip into the respiratory tract while taking it out. Best for soft meat boluses that may disintegrate with forceps. These are snares that can be rounded, oval, hexagonal, asymmetrical, of various shapes and sizes. These are hoods. It's a very important. Yesterday also sir touched upon it. Hoods are probably the most important accessory that's used to retrieve sharp foreign bodies. This is a diagram of a hood. It prevents injury to the gastric and the esophageal mucosa during retrieval. For initial insertion, the hood is inverted. It is flipped back over the endoscope itself. And as we grab the foreign body and retrieve the endoscope, the edge of the hood catches on to the musculature of the lower esophageal sphincter and flips back, or is deployed like a parachute over the foreign body. This is a video how the hood is deployed. This is how the hood is inserted into the gastric lumen. Now, when you are withdrawing the scope, the edge of the hood catches on to the musculature and gets deployed. This is a pin. If you can see, there is a pin impacted in the esophagus. See the pin, there is a pin in the gastric lumen, and they have used a forceps to retrieve it. This is also over the tip sheath we saw in the last video. It's a protective sheath that's used for better visualization while retrieval of the foreign body. This is a fish bone. If you can see, this is a fish bone impacted, large fish bone. They've caught hold of the fish bone and they're retrieving it. I have taken all these videos from Dr. Shottapriya Desharkar. All credit goes to him. None of them are mine. This is the overtube. We'll come into the details of the overtube. Overtubes are a protective device that protects the airway, and often multiple passes are required multiple attempts are required to retrieve the foreign body. So it prevents the mucosa from getting scarred and getting injured. The first time the endoscope is passed normally, and then the overtube is deployed. The overtube is put in position, and then you can protect the airway, and also you can have multiple attempts at retrieving the foreign body. repeated attempts at retrieval foreign body does not injure the mucosa. This is the anal. This is a soft food bolus impacted in an elderly lady. It's a some kind of fatty, oily, soft thing. They're trying to snare it. They've put in the snare and now they are trying to retrieve the foreign body. Yes. You can also use a roth net. They're putting in the roth net. Probably while using the snare, the parts of it was breaking off. So as a protective thing, they have brought the roth net to bring it out as a whole. This is a coin. The edge of the coin has been held by the forceps and they are trying to, this again they have deployed the roth net. Another coin, another foreign body in the gastric lumen. This is another, I think, battery, I believe. Yep. This is a fishbone at the epiglottis, the pyriform fossa, impacted at the pyriform fossa. It's a grainy video. You'll see the fishbone. This is a fishbone that has been taken out by the forceps. So you can see, depending upon the nature of the foreign body, we change and use different accessories. Sometimes we use the forceps, sometimes the roth net, sometimes the snare. It depends upon the position and the nature of the foreign body. This is a bone type of thing, hard, solid bone. Could be a food bolus that's being brought out. Again, we're going into retrieve a coin. Coins are very commonly swallowed by young kids and toddlers who can move about and have infinite curiosity. There you can see the outline of a coin. Yes, the coin is caught hold by a crocodile forceps, and now the edges have been caught and now the coin is out. Again, a clip, some sort of a clip or a sharp, I think it's a clip button. They are using a roth net again to take it out. They've deployed the roth net. You have to go beyond the foreign body and deploy the roth net and then drag it out under vision. Another video of a fish bone. Now these are the videos of removal of foreign body. Two types of foreign body deserve a special mention. The button battery, because it's a critical, and the button battery and its magnet, and secondly a drug packet. Drug traffickers often ingest packets of drugs as in drug mules or body stuffers, and they try to get through the airport. So the endoscopist is called upon to retrieve those things. So we'll see how and what to do in those cases, because these are special cases. Button battery ingestion is a time critical endoscopy. Conservative, when to do conservative? If the ingested battery causes no symptoms, no added magnets, and battery is in stomach or beyond, but asymptomatic. So conservative management, watch for 3 to 4 days. Generally it will pass. You have to inspect the stool every day, and generally it shall pass. When do we need endoscopy? If it is symptomatic, if there is a co-ingested magnet, if the battery is in esophagus, asymptomatic but persists in stomach for more than 4 days. It's been 4 days since the ingestion and it's not moving from the stomach. You have to take it out either endoscopically or surgically, because eventually the acid of the stomach will affect the battery and it will start leaking. So you cannot take that risk. Surgery, whenever endoscopy fails, we will go into surgery. There is no separate criteria. At any point of time when this endoscopy fails, we can move into surgery. Edible oils, there has been studies that edible oils forms a protective coating, a neutral pH protective coating around the battery, so that there is no alkalization of the polarity of the battery, and it does not damage the mucosa that comes in contact. It's a possible treatment option if feasible. And secondly, as I said, drug traffickers, drug mules, or body packers. This is a CT scan of drug boluses in the stomach of a body packer. He was trying to smuggle drugs through the airport, and this came out in the CT. These are the drug packets. This is how they pack they traffic drugs from inside their body. Most of these cases, endoscopic retrieval is generally contraindicated because any rupture may cause a fatal overdose. So close observation in asymptomatic individual who have concealed packets of drug by swallowing is the treatment of choice. Regular whole bowel irrigation with PEG, close monitoring in ICU setup, and serial imaging till clearance by CT scan is the way to go. Hardly ever endoscopy is indicated. If endoscopy is done, it should be done in a facility where there are surgical specialties available, there is ICU facilities available. Should not casually go into retrieve a drug packet. Surgical indications are emergencies where the packet has ruptured, there is intestinal obstruction, or failure of conservative management. Use of PP is both mandatory in a legal and biohazard perspective. Now, if we coming to the end of this presentation, we look into the future, like what are the softwares or the instruments that will help us in future to retrieve the foreign body in a more secured, more safer way. Gardas over tube that we saw, a flexible over tube that creates a protective conduit during upper GI endoscopy, enabling safe retrieval of foreign bodies while minimizing mucosal injury and aspiration risk. It gives mucosal protection, facilitates repeated access, aspiration prevention, and improved control and safety. These are recent advances. CAD-E is an AI system that automatically highlights the foreign body. Yesterday someone was showing, I think, CAD-E, as the endoscope moves into the lumen, there is a green marker that identifies a lesion or a foreign body, helping the endoscopist to know so that it does not miss any foreign body. E-suction is a cap-mounted endoscopic device. It integrates continuous suction with a snare leg mechanism. We have a good video of this, we'll show you later eventually. Talon is a four-pronged endoscopic retrieval instrument. EndoAngel is a very innovative platform brought around by Olympus. It's an AI platform. It monitors the blind spots. It says that with this software, the blind spots will reduce up to 60 to 70% for every endoscopist. Often the smaller foreign bodies or smaller lesions are hidden behind folds. That prevents the endoscopist from a successful retrieval. This will increase the rate of retrieval of foreign bodies. Then this CADEX system. CADEX system is also a form of CADI. It highlights any mucosal injury that has been caused by the foreign body, any rupture, perforation, trauma, so that this also helps a better outcome of the following the retrieval of a foreign body. Pillbot is not that important in this case. Pillbot is a swallowed pill, endoscopic swallowed pill. It can be maneuvered from the outside with the help of a motor, magnetic imaging type of thing that helps to drive the pillbot, and it can detect and help to retrieve or push the foreign body into a better position. This is a penultimate slide. This is the e-suction device, as we saw in the previous thing. It's a hood-like thing. It allows a snare to integrate the snare thing with a suction. There is continuous suction and with the snare, and you can deploy the snare like this. Goes in, the it snares the foreign body. This is a luminal view, and with the suction it can maneuver the foreign body better. Most useful was for sharp objects. The sharp objects is sucked into the hood and then retrieved securely with the help of a snare. This is a folded kind of a snare. Then this is the talon. Talon has a four-pronged tooth-like structure. It helps to retrieve softer and more friable foreign bodies that has been impacted in difficult positions. This is a video that we saw earlier. Same Gardus overtube is used, and the talon is deployed through the endoscope, four-pronged device that breaks out and retrieves the foreign body. The advantage of using the Gardus, I keep saying it, is you can repeatedly do the same procedure without injuring the esophageal mucosa or compromising the airway. In the hands of a surgeon, the scope is as good as a scalpel. I'm very thankful to the IGS board, the EFIGES board members, the organizing committee of Berhampur, and Dr. Satyapriya Desarkar and my friend Asim Manna. Thank you.
Very nice, comprehensive presentation. I just want to ask one question. In your initial slides, you shown that there are so many deaths occurring all over the world because of foreign bodies. My question is whether these deaths were because of foreign bodies or because of the process of retrieval.
Some due to mostly due to the sequel or the complication of the foreign body retrieval. Mostly perforations or impaction or aspiration without protection, whether you try to retrieve a foreign body from the GI tract and it slips into the respiratory tract. These deaths has been reported.
This is $1 million procedure that the patients won't die of body, they might die because of your act if it is not properly done.
Yes, I have not made any special slide for complications of retrieval of foreign body. The management of complication is only surgery. There is only few complication, that is aspiration, perforation and bleeding. In most of the cases, the patient has to go for surgery. And secondly, I would like to impress upon this that difficult foreign bodies like dentures, clips are always difficult to maneuver or retrieve. So for newer surgeons or newer endoscopists, it's better to not attempt it or attempt it in a center where there is facilities or super specialty help available, CTVS people available, general surgeon people available, because dentures and pins and sharp objects cause frequent perforations. Buttons and coins are comparatively safer. Not an issue, sir. Thank you.
Thank you, sir, for your insightful words. Any questions from the audience?
Even for normal endoscopy, we generally have to give some form of sedation or anesthesia to toddler, because otherwise it's very difficult to calm a toddler and do endoscope on a young patient.
I think for the foreign body retrieval, should have very low threshold
Yes,
to take help of the anesthetic or even the intubation. So that is only a life retrieval.
Incubation really made it much better.
Thank you, Chairperson, for presiding the session. Now, moving to the next session, respected delegates and esteemed faculties, welcome to this extraordinary session on live transmission of therapeutic endoscopic procedures.
We will have this simulators and cases are getting ready for live demonstration. By 10:45 we will have live session from AAG Hyderabad. So all of you can go for simulators. We'll have live demonstration of upper GI endoscopy, and then one or two cases we'll see we're checking for colonoscopy. And every one of you should assemble back to this place by 10:45 because we'll be having live session from AAG Hyderabad.
Hello, hello, check, hello.
हार्दिक सर रेडी है ना सर आप? आपका माइक। हाँ सर बोलो सर.
Yeah, hello.
Yes sir, ready sir?
Yeah.
Okay, I'll inform them sir. We'll start. पाँच छह लोग आ गए होंगे सर, स्टार्ट कर लेंगे.
మొత్తం ఐదుగురు ఉన్నారంటున్నారు. ఇక్కడే 10 మంది ఉన్నాం మేము ఈ రూమ్ లో.
Can you connect with AIG, please?
Yeah, we are ready sir.
Satish and
We
Dr.
follow your audio. Whenever
Extra.
we are ready, we'll start.
So first focus on us, then the doubt.
We will follow your audio sir, then we'll start.
Connection is there? Can we talk with them? Hello?
Hello, good morning sir.
Hello?
Hello. Hello, morning sir.
Calling from Bahrampur Medical College, EFIGS, waiting for the live.
Can you hear us sir? Hello. వినిపించట్లేదు.
Hello, can you hear us sir?
వినిపించట్లే వాళ్ళకి, నేను మాట్లాడుతున్నాను సార్, ఒక్క నిమిషం.
Hello. 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 Check. Hello. Hello. Hello.
కానీ ఎవరిని చల్లగా అరే ఇస్ पे फोकस कर सकते हैं.
Hello. Hello.
Hello? Hello? Can you hear us?
Yeah, we can hear you sir. Can you hear us?
Yes, I am Dr. Shatrughat Desharkar, convener of our EFIGS board. With me, our past president, Dr. Satish Midha is there, and Dr. Bijay Burgaonkar, our faculty. So we are all waiting eagerly to have the live demonstration on second day of our EFIGS program for the endoscopy training for the surgeons.
Thank you very much sir. We are starting sir now.
Yes, please, please.
Good morning sir. I hope you can see us and hear us well.
Yes, clearly and loudly we can hear. Please go on.
So for the next 2 hours, we have some really good cases. We have good diagnostic cases as well as therapeutic cases lined up. Some of them are basic, few of them are slightly advanced, but it will be really enjoyable. So we'll start off with the first case. Dr. Hardik is ready with the case.
Good morning,
Good
everyone.
morning, Dr. Hardik. Good morning. And we are eternally grateful to Dr. G.V. Rao for giving the permission to do this thing. Please go on.
So we'll be demonstrating certain cases. First, we'll start with routine endoscopy and to see how nicely or how standardized way endoscopy should be done. So we'll start with the first case, who is a 50-year-old male, known diabetic, who complains of pain, abdomen and vomiting and weight loss since 1 year. So family history is of upper GI cancer is there. So what we'll demonstrate is how to do a good zoom endoscopy. So as we know, upper endoscopy is a routinely done procedure. It's a outpatient done procedure. There are certain indications like dyspepsia, pain, vomiting, and upper GI bleed. But there are certain conditions like GI cancers, early GI cancers, which can be missed if there is not a properly done endoscopy. So we have now been training many doctors from the country on how to do a good standardized endoscopy. So that requires at least 6 hours of fasting, and the patient can remain on liquid diet at least till 1 to 2 hours before the procedure. An important thing that we have introduced in all endoscopies is the use of a defoaming agent in the form of N-acetylcysteine and simethicone. With that, we can see the stomach in a very clean way, along with pre-medication. So it is given 20 to 40 minutes before we do a good endoscopy. Along with that, we need a standardized endoscopy in which we give anesthesia to all the patients. We have a cutting edge state-of-art endoscope, that is a zoom endoscope that I'll be demonstrating shortly, that involves use of a soft hood cap, a black colored soft hood cap over the tip of the endoscope that prevents any trauma and that helps focus better. The 1200 series scope that has been given by that we use frequently at AIG is the state of art through Olympus. Yes.
I'm sorry, the mic was not on. So I was trying to say is that the scope comes on an X1 platform, which is the latest platform from Olympus.
So when we
we have with us anesthesiologist also in the room who have sedated this patient under short GA. Dr. Tejas is helping us with this patient. So he's on propofol sedation. So go ahead, Dr. Hardik.
So when we do a
specific advantage of this one, which you are using, the Zoom one, was 190.
So he'll demonstrate now.
This is 1200 series scope. So when we start, we see the area epiglottic folds, the posterior pharyngeal region, because the risk factors for carcinogenesis in the upper GI are same. Many a times the patient come with lesions in the upper GI and we tend to miss if we don't do a good endoscopy. So this I have intubated. While going inside, we switch on the narrowband imaging and see. So narrowband imaging is a specialized imaging with which we can see the blood vessels and any brownish area in the esophagus. So as we can see, I can zoom here and we can see if there are any specialized blood vessels. These are IPCL. So these are normally also seen. So with this scope, we can see up to 1200, up to 125 times zoom. So this we can see, if there is any brownish area, then we can focus properly and we can rule out any early esophageal lesions. Now we can see the GE junction, as we can make out very easily the difference in the mucosa. Below is the columnar mucosa of the stomach and upper is the squamous cell mucosa of the esophagus. So while we go in, as we can see this pattern of endoscopy, this shows atrophy. So with this scope,
using the white light, we can very well differentiate the gastric mucosal atrophy. The mucosal folds are diminished and the vessels have become prominent. There is a lot of nodularity over the mucosa, and there are certain criteria to tell the amount of atrophy that is present. These features are very well seen in patients who have treated with H. pylori or previously they have had history of H. pylori with development of various nodules here in the stomach. As you can see, once we go inside, we can focus on these specific nodules and we can tell the, as we can see, as we know that chorea cycle, that is the carcinogenesis pathway of H. pylori, develops from atrophy. It goes on to intestinal metaplasia, then the patients go to dysplasia and then early lesions. So if we can focus properly using narrowband imaging, we can zoom on any one region and we can specifically tell whether the patient is having any early gastric lesion signs or not. So there are certain criteria in which we tell the vessel pattern, the surface pattern, and then accordingly whether the patient is having changes of intestinal metaplasia or what are the prognosis of the patient going in early gastric cancer can be known. Then we go inside the duodenum. So classically, previously, people used to do endoscopy telling that we go in the duodenum, find the lesion. If it is there, if not, then come out and just finish off the endoscopy in 2 minutes. But now, because of the good scope and because of our learning through our Japanese colleague, we have been able to focus and find out early lesions better now. So that has overall improved the standards of endoscopy in the country. If we can see, we can zoom, and with this we can also see the villi, the duodenal villi. So while coming out, we have to insufflate properly, and we can see that the stomach is totally atrophied. There are Kimura Takemoto classifications to tell the amount of atrophy which can be closed type or can be open type. The more the atrophy, the higher the chances of going in malignancy. So as we can see here, there are 2 lesions in the fundic region which would have been easily missed had we not been used a good endoscope. So there are certain lesions here. As we can see, there is a demarcation line. When we switch on the narrowband imaging, we can see there is a demarcation line telling that there is certain early lesion here.
Sir, I hope you're getting the images well, sir. You're seeing this.
Very good images.
Yeah, so you're seeing this lesion where it is spontaneously oozing. So
Yes,
this also gives us an indication that it can be a suspicious lesion. So we need to look into it more closely. So what Dr. Hardik is doing is trying to focus on the lesion and trying to do zoom endoscopy. As you can see now, he's zooming in to look at this in a better way.
This is not contact oozing, na? It has not traveled through that.
Yes, yes, yes. So as you can see, there is a change in the surface pattern here on the area of the mucosa where there is normal mucosa, that is the atrophic mucosa. Hello, can you hear us?
Yes.
Yes, yes. So, there is this area where there is loss of the surface pattern as in that area.
There is a altered vascular pattern. We see it as the VS pattern, alteration in the vascular pattern and also in the surface pattern, along with the demarcation line. That is very much suggestive that the patient might be harboring, and looking at the background mucosa also with atrophy around and changes of intestinal metaplasia, the patient might be harboring an early gastric cancer here.
So as Dr. Hardik mentioned initially about the pre-medication, so this is how the stomach looks if we have given pre-medication. So defoaming agent, we generally use simethicone, and for the mucus to get lyzed, mucolytic agent is what we use as N-acetylcysteine. So we give this tablet form, or we also have a commercially available EndoView, which is as a premixed solution, which is given before the procedure. So he's getting very beautiful images. As you can see right now, this is in the antrum. So he's seeing the antral glands. As you can see, these are the antral glands.
So these are the changes which show the presence of intestinal metaplasia. So these are all stages in which the patient would have passed through over few years. So what we are recommending is that at least at the age of 40, a patient who has history of family history of gastric cancer or previously treated H. pylori should undergo a screening endoscopy, and maybe every 3 to 5 yearly they should undergo screening with a good high definition endoscope.
So here the features of atrophy are there absence of folds, as you can see, and there is pale mucosa all over. There are some red areas where we have focused on using a zoom endoscope, and there is thinning of the mucosa. You can see the vascular structures very clearly below the mucosa. So these are the features that tell us there is atrophy. Once we see atrophy, then we focus on areas where we see abnormal areas, such as red colored areas, what we are looking for. So there are few red colored areas like these also, which are vascular, and we focus on that using NBI and then the zoom endoscope. So this is a whole point of zoom endoscopy. So do you have any questions, or we'll move to another case?
Would you like to take biopsy from here?
Yes, so we
gastric
do a
cancer lesion?
systematic Sydney protocol biopsy nowadays, in which we take 3 bottles, 5 biopsies totally, 2 from the antral area, 2 from the antral area in which we take the greater curve, lesser curve, then 1 from the incisura, that is bottle 2, and then we take from the body. So this will tell whether their patient is having atrophy or not, and intestinal metaplasia. Plus we take the targeted biopsy from the lesions that we suspect. So we can in general classify whether the patient is having any stages of atrophy or not, and targeted biopsy also. So we will take at least 3 to 5 bottles biopsy in this case.
And label them properly so as
Yes.
to pathologist gets a good idea as to what we are looking for.
Yes.
So as Dr. Hardik is taking biopsies, we'll move to another room where we have another basic interesting case where Dr. Rajendra is ready.
Yeah, thank you, Dr. Pradeep. We move to next case where Dr. Rajendra is ready.
Hello.
Dr. Rajendra is going to showcase a new technology where you can increase the detection of polyps. Over to you, Rajendra. Yeah, please. You can briefly tell the history as well.
Yes, good morning everyone. I am Dr. Rajendra. With me I have my colleague Dr. Anudip. We have our anesthesia colleague with us actually. So I think we'll move from, I think you have seen the upper GI endoscopy. Now we'll move on to the second procedure, that is colonoscopy. This is basic colonoscopy, but along with basic colonoscopy, we also will be demonstrating 3 advanced technology. One is the scope guide, the second one is the polyp, AI polyp detection, that is the endobrain, and the third one will be also showing endocuff actually. So these are all accessory tools that we can use during routine colonoscopy to detect a polyp and also to characterize polyp. So here our patient is 58-year adult male who came with constipation, and for routine constipation we have suggested colonoscopy actually, and age is above 55, so where we also suspect chances of adenoma detection and all actually. So in short of time we have already intubated our colonoscope, and on screen I think you can see 2 images. One is the endoscope image, and on the left corner I think you can see a blue screen with a scope inside. So
Yes, no loop is there. It would be quite straightforward.
So first we'll show the scope guide. So now we can see the scope here. Scope is in reverse hockey shape or reverse P shape, hockey stick shape or reverse P shape. And we can see like real time looping of the scope also.
So when I'm pushing my scope, I think you can see that you can see a 3D image of the colonoscope actually, which is getting looped up actually. So these scope guides help us in many ways actually. It helps us to see the real-time movement of the scope actually, to prevent looping and also to prevent discomfort to the patient, because most of the colonoscopy in a lot of the centers are done without anesthesia actually. So this helps us to prevent coiling, help us to prevent discomfort to the patient. Also, it helps us to guide our scope in patient with who has a long colon or who has a looping colon, post-operative colon and all actually. So this help us to direct our colonoscope. Especially it is very beneficial for beginners actually, who are trainees or fellows actually, where they want to guide their scope and all actually. So
Now
this scope guide has a dish actually, or coil which are there in the colonoscope actually. So the coil in the colonoscope generates a low frequency electromagnetic waves, and this can be received by the receiver dish actually, which generates the 3D images actually. And also we have one more attached accessory to this actually, I think hand coil actually, where we can apply pressure when required actually. If there is too much looping and all, and if the assistant want to apply pressure actually, I think you can see a pointer here.
Where pressure being given, we can see that.
Yeah, pressure can be given in real time actually, the exact location where the pressure can be applied actually. So this is the scope guide technology, where 3D image of the colonoscope is reflected onto the screen to help us in detection of the position of the scope, to prevent looping and also to reduce the looping in real time actually. So now,
The next one is endocuff. This is from Olympus, which has a bristles in, it's a cap. So we can see this. This will be attached to the end of the scope, and around 1 centimeter distance will be there from the scope. These are the bristles which help in opening the colonoscopy folds, and that will improve the adenoma detection rate. You can see the green bristles here on the screen. They will help in detecting the, like opening the folds, and that causes increased adenoma detection rate.
Yeah, so I think on screen you can see yellow color flanges actually. So the endocuff we have attached to our colonoscope. So this flattens out the colonic folds actually, and it also helps us in adenoma detection rate actually. Because always in our colonoscopy, our aim is to detect the adenoma actually, so that we can early detect adenoma and prevent colon cancer actually. So these tools help us in extra adenoma detection rate. I think some study have shown around 3% increase in adenoma detection with just the help of this endocuff actually. And yes.
So this thing is so soft that it's not going to hurt the mucosa, na?
No, it is very, I think, soft plastic, made up of soft plastic actually. Okay. And while going, I think when you can see here, when we are entering or pushing our scope, it gets folded on backward itself. So when we withdraw, retract the scope, only it comes out. So it is one direction flanges actually. So when we withdraw, if you are seeing, now only we can see the flanges. Yes. So it is one direction soft plastic cuff actually. And I think it can be reused again and again actually. So I think we can save cost in, ideally it is a one-time use disposable cap actually. But with sterilization, we can use for multiple procedures actually.
So with 1% increase in adenoma detection rate, there is a 3% decrease in colon cancer. So that's why it helps
just
in
a disposable device.
Yes.
Yeah, we can dispose.
So you are almost routinely using this thing for all your routine cases.
Yeah, we are routinely using for any person who are where we are suspecting or we are screening for colon cancer or adenoma detection. So any person who has a risk factor for colon cancer or patient who is coming for screening for colonoscopy.
So anybody over 50 years of age, so with our any family history of colonic cancer or any cancer, so we'll do with the endocuff, so that it will detect adenomas and we can remove the polyps in same time.
What is the cost of this device?
Cost is hardly, it cost around less than 2,000 rupees actually.
Okay. And Olympus produces it? Who produces it?
Olympus company has tie-up with another company, so now you can purchase with Olympus company.
Okay.
So next we'll move to the hot topic, artificial intelligence with colonoscopy. It is called EndoBrain. This is also from Olympus. So we can see in the real time here, polyp This is called endobrain. It will detect the polyp and it will also diagnose the polyp also. So it is called CAD-I, CADEX.
Yes.
Okay, CAD-I will detect the polyp, CADEX will diagnose the polyp.
So while I'm withdrawing the colonoscope in real time, I think you can see the screen where the endobrain is on, and whenever it detects any polyp, actually it blinks actually. So I think whenever if there is any polyp, it
So it immediately blinks and says that there is a polyp is there, like.
so now I think
Yeah.
now I think you can see that polyp is there. So the screen has blinked and it has formed a yellow square shape. So it has detected the polyp actually. So now the second feature of this endobrain is the characterization actually. So once we have detected the polyp, we want to characterize whether it is neoplastic or non-neoplastic actually, because that is the most important problem actually, because we keep on taking biopsy from non-neoplastic polyp, or we try to resect, that adds to the cost of the patient. So for polyp characterization, we keep NBI image on and then we do freeze it. And on the screen you can see that it has told us it is non-neoplastic actually, that is it is non-adenomatous polyp actually. So this help us in avoiding biopsies, multiple biopsies from these polyps and all actually, and this also decreases the cost. Okay.
So we studied this endobrain and published in a Journal of Digestive Endoscopy. In that we found out that the polyp detection rate is improved and adenoma detection rate is also improved, and it has sensitivity around 98%. If she says neoplastic, it correlates around 98 to 100% correlation is there. Accuracy is around 98%.
How they make it that whether it is neoplastic or not? They will blink or something? How was that?
Yeah, like we will freeze it, then NBI, then freeze, and with the press of a button, it will tell you whether it is neoplastic or non-neoplastic.
So now again we have detected the second polyp. Yes.
It will be written on the screen that neoplastic or not.
Yes, I think so. Again we'll show you.
We'll show you again.
Yeah. So we got the second polyp. So now we are freezing with NBI. We are freezing, and on
So you
screen.
can see this non-neoplastic polyp.
So it is real-time AI detection actually. So it is within a fraction of second we can see it detects the polyp, it characterizes the polyp, and yes.
So it helps in if it is any non-neoplastic polyps, we can remove the discord also. Or it helps decreasing the burden on the pathologist.
Yes. And this is mainly useful for diminutive polyps actually, when polyps sizes are less than 10 mm actually, and it is sometimes very difficult to detect the polyp and all actually. So endocuff, endobrain, both can be used simultaneously. This adds up to the polyp detection or adenoma detection rates actually, so that we the miss rate of polyps can be, or adenoma can be less actually. So I think we have demonstrated 3 technologies: scope guide, endocuff, and endobrain. I think
we'll about this one because we all are seeing this thing for the first time live.
Yes.
Yeah, thank you, Dr. Rajendra. It's an excellent demonstration. It shows us the excellent efficacy of endocuff vision for detection of polyps. We move on to next interesting case where Dr. Chandana is ready.
Very good.
Yeah, over to Dr. Chandana.
Hi everyone, myself Chandana, and am I audible?
Yes, audible and visible.
Yeah, okay. Myself Chandana. So the patient is ready with the local sedation, and my anesthetist Sumalata, she is here. And so now we are going to demonstrate about the enteroscopy. So previously, traditionally for the small bowel evaluation, we usually have the old techniques like small bowel follow through or like CT scan. But with the advent of the advanced endoscopist, we can actually visualize the small bowel mucosa. We have like new modalities like capsule endoscopy is there, and other is the device assisted enteroscopy. So for the capsule, actually this capsule is like the main advantage is that we can completely visualize the mucosa, but the only limitation is there won't be any therapeutic advantages if the patient is having any bleeding or if we want to take any biopsies. But with the advent of the device assisted, we can go through that and we can localize the lesion, and if any therapeutic procedures is needed, we can take the biopsies, and if the patient is having any bleeding, we can go through the clip application. So the main indication for the small bowel enteroscopy is to, if any patient is having an occult GI bleed, or any patient is having to establish the diagnosis of Crohn's, and in the Crohn's, if the patient is having any stricturizing disease causing a subacute intestinal obstruction, we can do the therapeutic procedures like balloon dilatation and sometimes stricturoplasty also. And this is also useful for retrieving of the foreign bodies. And in some cases, like in any patient is having any altered surgical anatomy, then if you want to go for an ERCP, we can do the enteroscopy guided ERCP also. So there are, like in balloon assisted, there is a like single balloon assisted enteroscopy, double balloon assisted, and motorized spiral enteroscopy. But right now the motorized spiral enteroscopy is out of picture. We only have the single balloon and double balloon assisted enteroscopies. And right now I'm going to demonstrate about the single balloon enteroscopy. So I think you can visualize here, this is an enteroscopy which is having a overall length of 200 centimeters. The actual length is like 235, but the work length is like 200 centimeters. With the overlying diameter of the scope is like 9.2 mm. And there is another thing, this is like a device assisted, which has the balloon over the scope, which help us to go through the deep insertion of the enteroscopy. This is the balloon assisted, you can see here. This is a single balloon actually. In this, the distal tip will have the balloon, which we can insufflate so that it will anchor the small bowel mucosa. And this is the single balloon, which is like the overall length is like 135 centimeters with the over tube diameter is of like 13.2 mm. And this is the balloon. Actually, with the insufflation, it will hold the small bowel mucosa. And after holding the mucosa, will advance the scopy. So the small bowel will pleats over the mucosa. We can like a push and pull technique, the small bowel mucosa will pleat over this thing so that the shortening of the small bowel mucosa will happen and further deep insertion of the enteroscopy will happen. This is the main basic principle. This, with the help of the overtube containing the balloon, we will pleat the small bowel mucosa and will advance the scope into further. So this is for the main principle of the enteroscopy.
It is like in simple term, if you want to say, it is like putting a nada into a pajama actually.
Yeah.
So I think everybody is aware of that. So it is like pleating technology, push and pull technique. So as Dr. Chandana has said that it is a device assisted. So we require two persons to demonstrate this procedure or to perform the procedure actually. The gastroenterologist, and we also need a technician actually who help us to hold the overtube, advance the overtube actually, and during the pleating we require to pull the overtube actually. So I think in short of time, I think Dr. Chandana has already entered the enteroscope into the cecum actually, and she will be intubating the ileum.
Yeah, right now I'm in the cecum, so I'm trying to visualize my IC wall.
So entering colonoscopy or doing colonoscopy in enteroscopy is like a normal colonoscopy, except for that the enteroscopy is more flexible than the rigid colonoscope actually. Sometimes there can be extra looping or there can be fall into the sigmoid colon because of the flexible nature of the enteroscope. So once we enter terminal ileum, the scope is advanced further till we reach a maximum length. Subsequently, overtube is pushed over the enteroscope, and then we inflate the balloon, and then we pull both the enteroscope and the overtube actually. So to pleat the bowel. After pleating, then we deflate the, we advance our enteroscope further, and then we deflate the balloon and then push the overtube actually. So it is push-pull technique. So Dr. Chandana has already entered terminal ileum.
So I'm asking my technician to pull the overtube, pull it till 50.
Yes. So now, if you can see, the technician is pushing the overtube, and
I'm trying to advance my enteroscopy through the overtube.
So also, you would have seen that at the tip of the enteroscope, we have attached a cap actually. So transparent cap actually. This also help us to further advancement of enteroscope and also to unfold the mucosal folds. And this help us in attaining more length of insertion.
Yeah,
What
great
about the
demonstration.
patient?
Chandana, can you briefly tell the history of this patient? I mean, what is the
Yes.
indication of enteroscopy in this patient?
So this patient is having recurrent pain abdomen, sir. On evaluation, we found that previously he on mesenteric lymph node. This is a 19 years old male presented with colicky pain abdomen, and for the last 1 year he received ATT for the granulomatous mesenteric lymphadenopathy. There is outside they took the biopsy, and as it shows the granulomatous, there is the patient received ATT, but there is no improvement in the general condition after the ATT. So he came to here for the evaluation. In intestinal ultrasound, we found that the whole ileum is like thickened, having a stricture. So, and here the fecal calprotectin is 673. So we planned retrograde to take the biopsy and gene expert.
And
You are suspecting IBD.
we are suspecting IBD and
You are suspecting IBD in this patient
yeah, we are
because
suspecting.
of the raised fecal calprotectin,
Yes, and our
Crohn's or something especially.
yes, suspecting Crohn's bowel disease of the small bowel. The routine colonoscopy done here at AIG was normal actually. So we plan to do retrograde enteroscopy.
Sure.
The enteroscopy has both diagnostic and therapeutic properties actually. So for now we are using for a diagnosis. If we find a stricture, we take biopsies and prove this is as a small bowel stricture as in Crohn's. Subsequently, when patient is on therapy and sometimes there is fibrotic strictures and all, we can do balloon dilatation or stricturotomy with the help of enteroscopy actually. Also, other thing to keep in mind when we are doing enteroscopy is we try to keep CO2 insufflation as minimum as possible actually. We try to inject saline or normal saline actually, so that to prevent more insufflation of the bowel loops actually and help us to have a deeper intubation of the small bowel actually. And sometime we also do underwater enteroscopy where we switch off our CO2 insufflation, keep on pushing water into the small bowel, and under the water we try to advance our enteroscope actually. So some studies have shown that underwater enteroscopy slightly increases the depth of insertion as compared to CO2 insufflation. And also enteroscopy sometimes can be used during intra-op procedures actually. So whenever there is a tight stricture or multiple strictures and surgeons decides to do resection of the small bowel. But usually whenever we want to resect only the tight stricture, during intra or laparotomy, we do an enterotomy. During the enterotomy, we pass our scope and then we do intra-op enteroscopy in the proximal and distal segment to decide the length of the bowel involvement and help surgeons to have a resection planned actually. So also you can see under fluoroscopy, I think we'll also show a fluoro image where we can see how our enteroscope is placed actually. It is a long loop and the tip is forming a coils actually. So the deeper we go actually, it forms more coils actually, more and more coils. So that also help us to see how far we have reached into the small bowel actually. And when we are pleating the bowel also, it helps us to see that the bowel loops are pleated up actually. Routinely, we don't require fluoroscopy for doing enteroscopy, but for the purpose of demonstration, we have used a fluoroscopy or we are doing enteroscopy under fluoroscopy. Also, when we are doing therapeutic enteroscopy, that is stricture dilatation, or we want to see the length of the stricture, want to see the number of strictures, want to see how far the two strictures are placed, we inject dye contrast at the stricture site and see the length, the number of strictures, the nature of the strictures, and help us during therapeutic enteroscopy. Maybe that time we use a fluoroscopy, but routinely we does not require fluoroscopy doing during endoscopy procedures.
So right now I have inflated my over tube and I'm asking my technician to deflate and push the over tube.
So I think
Deflate.
for doing an endoscopy, we require a lot of patience actually. For beginners, it may take around 45 minutes to 60 minutes. Sometimes it may go on for 90 to 120 minutes to perform the procedures actually. Over a period of time actually, I think you may achieve a deeper insertion with a shorter time actually. So the insertion, depth of insertion depends upon so many factors, the body habitus of the patients, post-operative appearance actually, the learning curve of the enteroscopist, and the pathology, underlying pathology. So it requires multiple sessions of push and pull technique actually, where we try to go inside, then we try to inflate the balloon, pull our scope or pleat the bowel loop. So we try to pleat the bowel loop each time when we are coming back. So it pleats around 10 to 15 centimeter in one go actually.
Array. Deflate.
Is there any contraindication for enteroscopy like previous laparotomy?
No, there is no contraindication for previous laparotomy. But if
The depth
you know that patient has undergone 2 or 3 surgeries, then it may be difficulty during enteroscopy, because there may be lot of adhesions, and pushing our enteroscope or over tube, we might find resistance or find difficulties actually. But in post-operative cases also, we can do device-assisted enteroscopy.
So we can see the ulcers here right now.
I think Dr. Chandana has found the ulcers mucosal nodularity at around, I think, 100 to 120 centimeter from the IC wall actually. So it may be around mid ileum. So we were suspecting Crohn's disease in this patient. So this patient
These
has
multiple skip areas of superficial ulcers we have found right now. So from this, we are going to take biopsy and gene export to confirm whether it's like Crohn's or not.
Yes, but not much narrowing there.
No, I think we have to go ahead to find out the any narrowing is there or.
I think she might be proceeding further actually. So if there is no
Yes,
narrowing, we
Take
want
the
to see that,
biopsies.
because imaging wise there were strictures.
Typical deep ulcers and skip areas, long skip areas.
Dr. Rajendra, how do you decide the end of this procedure? Do you stop when you find the ulcer, or do you stop, or how long you keep on going?
So,
If the patient.
end of the procedure is when we surely know that we have found 2-3 skipped areas of involvement actually. So we stop, or if there is a tight stricture where we cannot further proceed, or if there is a deep ulceration.
Do you feel diagnostic yield is important, or the pan endoscopy is important?
So diagnosis is important, not the enteroscopy actually. The depth of insertion is not important. Achieving a diagnosis or reaching to a diagnosis is important actually. Especially for suspecting Crohn's disease, we stop after finding ulcers and all actually. But whenever we have suspicion of small bowel GI bleed actually, we find angioedema, we try to go further, because the other angioptasias deeper inside, where we want to obliterate all of the angioptasias.
Just a moment, Rajendra. Sir, there are some mic sounds from there. Please mute your mic, people who are online. May I request people who are online, please mute your mics. Thank you.
We are again seeing multiple skip areas of superficial ulcers here.
So I think
if it comes as Crohn's disease, what treatment are you preferring here? Any steroid or any biologic or anything?
So the treatment.
Broad outline.
Hello. So for the
Suppose
treatment,
this one comes as Crohn's.
yeah. So the treatment of Crohn's depends on so many factors.
Okay.
So now we have young patient who is less than 30 years, who has multiple skip areas of involvement of small bowel, and if we find stricture, so that also adds up to this actually. So we may have, I think, 4 or 5 high risk factor in this patient. So first line therapy for this patient who has more than 4 or 5 high risk factors will be always biologicals actually. Biologicals will be the first line therapy actually.
Okay. Thank you. Thank you. Thanks a lot. Excellent picturization. A big hand for madam.
Thank you.
Yeah, thank you so much. We move on to next case where Dr. Swapnika is ready with the interesting case. Swapnika, you can go ahead with the presentation.
Hi. So,
Deep, you're on.
Hello, Dr. Swapnika will be performing the procedure. I am Dr. Anudeep. So this is a case of cirrhosis. We can see the slides there. 60-year-old male. This is a known case of CLD for 5 years. And endoscopy showed grade 2 esophageal varices with red colored sign. We'll be performing endoscopic variceal ligation.
So, in a patient with CLD, when you do an endoscopy, you have to see various things. First thing is you have to see whether patient is having GAVE, that is gastric antral vascular ectasia. So here you can see these red color spots in the antrum. These are the GAVEs. Second thing, we have to rule out if the patient is having any fundal varices or not, because based on that, we'll decide whether you have to do banding or we have to do glue application. So this is the fundus. You can see both lesser curvature and greater curvature. There are no fundal varices. Then next, these red spots, what you see here in the fundus, these are the signs of portal hypertensive gastropathy. And now, while coming out, you have to see whether patient is having varices. If yes, what is the grade and are there any red signs? So usually the varices, there are different zones, what we see. One is the gastric, patient does not have any gastric varices. Then coming to the GE junction. So this is the GE junction. And above the GE junction, usually there are different layers. One is palisading zone, one is perforating zone, and one is truncal zone. And in this patient, as we come out, the columns which you see at 3 o'clock, 6 o'clock are the varices. And this red color lines, what you see are the red signs. And this patient had history of bleed 5 days ago in the form of melena. So since he has big varices with red signs, this is an indication to do variceal ligation. And previously also patient had history of bleeding and banding was done. We can see the scar over here at 3 o'clock position.
So these will grade as grade 2 or grade 3?
Patient has both, sir, grade 2 and grade 3. So grade 2 columns are around 3 o'clock. Grade 3 columns are around 6 o'clock and 9 o'clock position.
Sure. Thank you.
So now we'll perform the band ligation.
So as the patient is a bleeder case and with the child B status with red color sense, so we'll perform endoscopic variceal ligation. So we'll be using this Cook multi-band ligator. It has 6 bands. So it has a cap with 6 bands. It will be mounted on the tip of the scope. Then after that, we'll go inside with that band. So we'll be showing now live. Yes. So audience, any questions, you can ask the question. So while loading, we'll answer the questions.
These red signs were any of the stigmata of hemorrhage? The small red signs?
Possible. So the red color signs indicates that there is a recent hemorrhage and there is a risk of rebleed also. So patient has already had melena and there are red color signs. That means that there is a high chance of rebleeding. Then we have to intervene. So we can show that this is the cap here. This is a multi-ligator cap with 6 bands. So this will be used for placing the band. Once we rotate this in clockwise direction, the band will be deployed. So for every one rotation, there will be one band will be deployed. So we'll use the suction button to get the varix into the cup of this mounted cap. And then after that, we'll deploy the multi-band ligator.
How long back the previous EVL was done in this patient?
Around
once.
Previous EVL was done.
It was done 3 months back.
Okay. Because second time, sometimes the mucosa become much thicker, so it is not that easy like first one.
That's a very valid point. Definitely we have to keep it in mind, and we have to be very careful while performing when there is scarring also.
Yes.
So there is a chance of sometimes there will be a bleeding risk also will be there. Band mal deployment can occur.
So here you can see the GE junction. Basically, we band about 1 to 2 centimeters away from the GE junction. And here this is the variceal column. We have to suck and wait till the variceal column becomes red out. It's called red out sign, and then we deploy the band. And after that, we have to wait for about 2 to 3 seconds and then inflate and remove the cap. Because if you remove immediately, there's always chance that the band might slip. So after this, you have to do the band ligation in a spiral way, about 1 centimeters gap between the two bands. So this is the variceal column. You are doing suction and getting the red out sign and then deploying the band. and we can band up to about 25 centimeters from the G junction, and beyond that we can't band because there's always chance of post-tibial ulcers and chance of rebleeding. So this patient had only 2 columns which needed banding, and the banding is completed.
So other than this banding, if patient, as you asked, if there is a scarring is there, that time
Madam has done. So now, is there any role of sclerotherapy? Because we all old people started with the sclerotherapy, then the band came. Now with all we are doing only band, is there any role of sclerotherapy for the residual small varices if they bleed?
Ideally, we don't perform sclerotherapy in this esophageal varices as of now. So because band ligation is more better compared to sclerotherapy.
Dr.
In
Anudeep, one
pediatric
more,
population, we perform sclerotherapy even in CLD patient with hemorrhoids, where there is a high risk of ulcers and the bleeding risk. Those patients, we prefer doing sclerotherapy for hemorrhoids.
yeah, Dr. Anudeep,
Yes.
do you use all 6 bands in all the patients, or do you limit it to the number of variceal columns?
So it depends on the variceal column only. So if it is required, we can use all the 6 bands. If it's not required, if it's as Swapnika told, if it is more than 25 centimeter, less than 25 centimeter, there is high chance of ulcers. There is a risk of ulcer bleed also. Post-tibial ulcers bleed can occur.
And
So
how do you follow these up?
So generally, ideally, we perform monthly endoscopy, and until there is a variceal ligation, for complete variceal ligation, variceal obliteration achieved, then after that, the 6 monthly or once a year based on the patient child status.
So if there are coexisting fundal varices along with the esophageal, do you treat esophageal first or fundal varices first?
So that is a very important question. Whenever there is a fundal varix there, ideally we have to treat first fundal varix, then only we treat the esophageal varices. The principle is whenever you treat esophageal varices, there is a rise in pressure in the fundal varices. They may blow out and they can cause catastrophic bleeding also. So ideally, whenever fundal varix is there, we have to treat the fundal varix, then we have to go ahead with the esophageal varices.
That's a very important message. Great demonstration, Dr. Swapnika and Dr. Anudeep. Thank you so much. We move on to
One question that after the fundal varix, what is the time period you should wait for going for the banding? The glue injection you did for fundal, then what should be that minimum time difference?
same
Then we
sitting
go
you
for
can do it.
So
EVL.
if we do today banding, today fundal varix glue, then next day we'll do relook and we see that there is no active bleeding and the glue cast is in situ, then we perform the esophageal variceal ligation.
Yeah, thank you, Dr. Anudeep.
24 hours after you can do. Thank you. Thanks a lot.
Yeah. We move on to next case where Dr. Kriti and Dr. Pradev are ready. Yeah, Dr. Kriti, you're on.
Yes, hi. I'm Dr. Kriti here, and I have with me technician Santosh. Dr. Tejas has given the anesthesia, and Dr. Pradev is here. So today we are going to do a polypectomy. What I'm seeing is a very vascular polyp seen on the anterior wall of the stomach. It would be a
So we have the history here. So it's a 40-year-old male presented with fatigue and abdominal discomfort, lab showing anemia, and endoscopy showed a gastric polyp. Colonoscopy was normal. So the plan is to do a polypectomy. So to discuss further here, as Dr. Kriti has already scoped the patient, you can see this polyp is in the distal body, I think, and on the anterior wall. This is on the anterior wall along the greater curvature. So you want to describe the polyp a little, Dr.
yeah.
Kriti?
So actually, when we see a polyp, we have to first see the location, number of polyps, the surface pattern, and we can also characterize the polyp based on that. So here we see that it's a single polyp in this area with a size over 1 centimeter, and it's quite vascular. Okay, and if we see it, we should, when we see the surface structure, we should see the mucosal pit pattern, and we have to also see the vascularity. So based on that, actually polyps are divided into 3 types. 3 fundamental types: fundigland polyps, hyperplastic, and adenomas. And this is a vascular polyp, which is likely to be a hyperplastic polyp.
Why do you say so?
So usually hyperplastic are single or few polyps, and they have this reddish inflammatory look. They'll have a normal vascular pattern, at the most irregular. We can also see on NBI.
Correct.
And it has surface erosions and this slough-like, mucus-like appearance, which is more in favor of a hyperplastic polyp.
So fundigland polyps have almost the same color, or the texture would be same as the surrounding mucosa, is it?
Yes. So fundus gland polyps usually you see in the fundus and in the body of the stomach. They're very small, around 3 to 5 mm, and they'll be almost like the mucosa, glossy in nature. And adenomas on the other side, other hand, would be solitary, and they would have an irregular surface and pit and vascular pattern.
And you have a surrounding mucosa of atrophy and all that as well. That is also important while describing an adenoma. When suspecting an adenoma, we'll have to look for this. Here, the surrounding mucosa looks okay. There is no atrophy or anything. There's some edematous areas around the edematous area around the polyp, but otherwise there's no features of atrophy. That's the reason we are not thinking of an adenoma. So,
according to Paris classification, what should be this one?
So this would be a 1 PS where it is subpedunculated, you can say.
Okay.
That's actually a very good point which we were going to touch upon next. So you have to classify the polyp based on the Paris classification, and then you can also do a Kudo pit pattern to know whether it looks dysplastic. So this it looks subpedunculated. So since it's more than 1 centimeter, removal is warranted, and what we'll do today is a hot EMR technique where we lift it and then we will cut the polyp.
so Dr. Kriti is using a sclerotherapy needle that is available.
This is a 23G sclerotherapy needle. So I'm putting it in, and then we will inject indigo carmine mixed with
normal saline.
saline at the base to lift the submucosa.
So you're not using the adrenaline. Diluted adrenaline you are not using.
It depends on the operator as well.
It is quite vascular, that's why I just asked.
Correct. We can definitely use adrenaline as well, but in our practice we tend to avoid it, not use it often, because sometimes what happens is this: while you use an adrenaline to inject, what happens is you don't see a bleed during your procedure. Which is a false reassurance, and then once you get done with the polypectomy, later on the same day or the next
Polypectomy
day,
bleeding chances are very more.
yes. You might miss out on sometimes finding this bleeder. So that's the reason we avoid. But yes, it is definitely useful to use an adrenaline, especially while we are doing ESDs, especially in the stomach, or EFTRs. There are these GIST or some vascular lesions which are highly vascular. These lesions, we see a lot of bleed while we are dissecting the mucosa, while we are dissecting the submucosa. So in such cases, we add adrenaline to the solution we put in. So here you can see she has a very good lift here. This is a very good lift, Dr. Kriti.
Yeah. So I'm satisfied with this lift. Basically, I injected all around to get a good cushioning.
That will avoid one thing is it will avoid any deeper injury to the muscle, or very rarely it will also avoid perforation, especially if we are doing it in colon. We would look for an even better lift. Here the lift is fine for the gastric part.
Yes. So now I have inserted a snare. This snare is a 2.5 centimeter snare. Open.
So this is a snare from Olympus which we are using. So she's trying to garland the snare around the polyp to the base of the polyp. This is
round or hexagonal? Round shape.
Round one. And because the polyp is little leaf-like, it sometimes makes it little difficult to put the loop down below onto the base. She has very well got this to the base.
Yes.
So he has closed the snare, and now I'll be using cautery to cut.
So we are using an endosurgery unit from Irby. So the settings she has for this case is EndoCut Q 222, that is cut duration 2, cut interval 2, and also the current effect being 2. This is what we use. This is a Irby YO3 machine which we have.
So now I'm going to start the cutting. I'll use EndoCut, so it gives a coag plus cut mode. It reduces the tissue injury as well as prevents the bleed, very comfortable to use.
So as you can see, she's using endocut and she's not doing tap tap. She's doing continuous endocut because it's important to do continuous, especially with endocut, because there is this interrupted current. Not any of these currents which we have are not pure currents. They are usually sandwiched between like the endocut Q has some coag and as well as cut current that is alternating. So when you have such currents, if you don't give a continuous energy during the cut, it doesn't happen properly. So the cut and coag happens alternatively. So when you're using a yellow pedal, that is the cut current, you need to do a continuous current. Whereas when you're using coagulation current, the blue pedal, that we use intermittently, it's okay. But when you're using cut currents especially, we should use the coagulation, we should use the pedal continuously. So as you can see, the base, you want to coagulate because there is one vessel.
No bleeding.
Yes, we can coagulate it or we can place a clip directly too. That's fine.
Yeah. Do you see a vessel there in the base?
Yes, there is a vessel
Yeah.
there.
Ideally, you should be
We'll
put a
So
clip.
that's what we were discussing. So that is what
So
we were discussing.
the base is deep and actually these can bleed later on. So it's better to coagulate now and then to
You can see
clip it up.
nicely, you can see the bluish discoloration there on the base. So we are sure that we have not reached below onto the muzzle. It is not very deep into the muzzle or not. We are not seeing any muscular fibers as well. So we have that cushion still, even though if you do a coagulation, it might not cause any collateral damage or it might not cause any problem.
This is a very nice case for delegates because this is the ideal case where you have to put a clip. If you don't put a clip in these cases, as he has already said, there is bound to be reactionary hemorrhage or secondary hemorrhage on the second day or something. That will really be a bothersome. So ideal is to put a clip.
Yeah, she tackled this very well. She used this coag grasper to hold the vessel which we are seeing at the base.
Dr. Pradeep, what is the preferred setting for coagulation, what you are using now?
Oh, so we use soft coag. Soft coag is what we use as for coagulation. So she used soft coag effect 5. We can use anywhere between 4 to 7.5 soft coag. That is what we use generally for soft coag. To use when you use a coag grasper, we use soft coag for the coagulation.
So also, if you feel you cannot hold the vessel, you can use the tip and press also. That's what I did in this case.
So in Olympus, this is a new scope with the new platform which we showed earlier. So this has a new mode called RDI. So you're seeing this RDI. We wanted to demonstrate this, but we didn't have a bleed. If there is a bleed, we see this amber color. You're seeing amber color. Blood is
the brownish shade.
Yeah, blood is looking more brownish yellow. So if you see a bleed, you will see this amber color, and you will see this color more, intense in the area of the bleed. So if there is a lot of bleed and you can't identify where the bleed is happening, you can switch on to RDI, where you can identify the bleed point and coagulate effectively, rather than keep coagulating in different areas where you might miss doing coagulation and there is more bleed, there is a pool of blood and you can't identify.
That's one of the AI thing, na? Artificial.
No, it is a new imaging like NBI. This is also an imaging where you use red diachromatic imaging. RDI is red diachromatic imaging. So it has a specific wavelength of light which is emitted by it. So it also has two modes, RDI1 and RDI2. So RDI1 will help you identify bleed points. RDI2 might help you identify any bleed and any vessels which might be deep inside the submucosa. So we use RDI accordingly.
The visibility increases.
Yes. So we are trying to clip this defect because not that it will perforate or anything. We are trying to clip this to prevent delayed bleeds.
So we have a Medora clip here, which we'll be using now. So also one more thing to be noted, hyperplastic polyps actually are associated with background of gastritis. So you should look out and rule out atrophic gastritis, H. pylori in such cases.
So she's trying to use the clip not just to approximate nearby. We are not trying to close the defect as such because we are looking for hemostasis more than trying to close the defect. So we need not place it exactly on the place on the defect. We can slightly approximately near the lesion as well. We can use the clip to close the defect. So so as to avoid delayed bleed. So you can see here she closed the clip. This is a reopenable clip, so she asked the technician Santosh to close the clip. She saw it was fine, but she's not happy with it, so she's trying to open and reopen and trying to get a better grasp of the tissue.
And we can always put 2 clips if we cannot get the whole.
Yeah, I think suction will help you to get the tissue more closer, and that will help you get a good grasp of the tissue. So you can see she's sucking now. Now she gets a better grasp. I think this is good. We can deploy the clip. Yeah. Yeah.
Slightly to the side.
It's okay. It is mainly that we are trying to avoid delayed bleeds. We're not trying to close the defect. So it is okay if we are little away from the lesion as well. So we put another clip here. If you have any questions, we will be happy to answer.
Retrieval of the specimen, what you do, Rotnet, which way you will use?
Yeah,
retrieval of the specimen.
True. We can use a Rotnet. Sometimes, because this is a very leafy kind of lesion, probably Rotnet is a better option. If it is a very tough structure, which might be difficult to get out of the stomach, especially at the G junction, we try to use the snare sometimes where it is difficult. Yes, it's okay. So we use a snare as well. Sometimes if it is a very small lesion, we try to use just the suction of the scope, get it into the cap and get it out. So that should be fine. So you can see here.
Nicely close. Absolutely.
Yeah. Very beautifully done. So we will try to get out the lesion using a Rotnet. So
for the madams.
Thank you, Dr. Pradeep, Dr. Kriti, for the excellent demonstration. We move on to next case where Dr. Gautam is ready. And this is a very niche area because most of the times post some surgical recovery or surgical complications, we tend to see fistulas, which are very difficult to treat. Earlier, we used to treat them cosmetically, like applying some Ovesco clip or multiple clips. These are difficult procedures. So we have started a niche area, which is led by that program of regenerative medicine is led by Dr. Gautam, Dr. Rakesh, and Dr. Swapnika. So, Dr. Gautam, over to you.
Thank you, sir. So, good afternoon, everyone. So, as you can see, we don't have a live case to demonstrate for you today. But this regenerative endotherapy, we started this program to address some of the most needed situation in our day-to-day practice, especially in patients with chronic GI fistulas. It could be spontaneous, it could be inflammatory bowel disease related, it could be iatrogenic, it could be post-operative, post-radiation. But I think even the audience and the esteemed chairpersons would also agree with me that these are probably some of the most difficult cases to manage in our GI practice. So there are a lot of endoscopic techniques already in place, as Dr. Anirudh has already pointed out, but they have their own limitations in managing these cases, and the closure rate is among all the endoscopic closure techniques is somewhere around 50 to 60%, and surgeries in these situations are pretty morbid as well. So we have started the regenerative endotherapy program. Acknowledgements to our Italian colleagues in this situation. So in regenerative endotherapy, what we basically are using is the potential of the mesenchymal stem cells. But as we know, the routine usage of stem cells using the bone marrow or umbilical cord are pretty difficult to obtain, pretty difficult to culture, and regulatory approvals are a hassle. So we have now started using our fat tissue, adipocyte tissue, as a source of our mesenchymal stem cells, and we are going to show you how we are extracting the stromal fraction with minimal manipulation, and it's very easy and reproducible and very cost effective. Can we have the first slide, please? So the first case we are going to showcase is a case of a rectovaginal fistula. This is a 64-year-old female who was diagnosed in 2007 with CA cervix and eventually underwent surgery and radiation. Then she developed a rectovaginal fistula, for which surgery was done, but then she developed a recurrence later on. This patient was referred to us for the management of the fistula endoscopically. Because of dense adhesions, the surgeons were not ready to operate. So on sigmoidoscopy, you can see that there is a huge fistula opening between the rectum and the vaginal cavity, almost of a size of 1.2 centimeter, and the endoscope could be passed easily into the vaginal cavity. So this patient was taken up for endotherapy using our autologous adipocyte stromal vascular fraction. In this patient, the first step would be to harvest the fat from either the thigh regions or in the abdominal fat region. In this patient, we use the thigh region. We inject a subcutaneous tumescent solution, and then using a 2.1 mm micro cannula, we harvest the fat. This is a simple step where the plastic surgeon is helping us out in extracting the fat. They do this day to day for obesity and bariatric procedures for liposuction. And for us, we just need around 80 to 100 ml per session of fat for the usage of SVF therapy. Once the fat is harvested, it is then subjected to mechanical emulsification. This step is different to the routine chemical emulsification that is necessary in the stem cell practices earlier. So this is very easy. These filters are reusable. They can undergo processing, sterilization and reused multiple times. Following mechanical emulsification, the sample is centrifuged at 3000 RPM for 3 minutes. And the middle layer that we get is what we call as a tissue stromal vascular fraction, and this contains the mesenchymal stem cells, and along with that various growth factors and anti-inflammatory cytokines as well. So here this SVF is injected using a 19 gauge needle in and around the fistula site, so that the tissue regenerates and helps us close the defect. So because this takes a lot of time, we usually ask the patients to review in 4 to 6 weeks time. And if we see a partial healing, then we attempt to do the second session and third and so on if necessary. This particular patient received 2 sessions of regenerative endotherapy 4 to 6 weeks apart. And 12 weeks down the line, we asked the patient to follow up, and this was a sigmoidoscopy after 12 weeks. If you can remember, there was a 1.2 centimeter fistula and the scope was easily negotiated into the vagina. But here now we have seen that there is complete closure of a 1.2 centimeter fistula with good granulation tissue, and there was no residual fistulous communication left between the rectum and vagina within 12 weeks of this regenerative endotherapy that is minimally invasive and done in a daycare setting. So this is a very potentially wonderful technique for chronic fistulas and avoiding major surgeries for enterocutaneous fistulas as well. So again, the treatment requires very minimal manipulation of the adipose tissue, and the entire procedure is done in 60 minutes. So as you can see, from the first visit to 12 weeks, you complete closure of a 1.2 centimeter fistula. So we are going to demonstrate 2 other situations where we used a similar technique. This is a 67-year-old male with a foreign body ingestion. The foreign body was removed endoscopically, but there was a transmural defect noted on endoscopy. And even after 3 months, this patient had a persistent esophageal leak. Can we have the next slide, please? So the video demonstrates, the barium demonstrates the leak that can be seen, which is persistent. Patient was unable to have food for almost 3 months. He was on RT feeds for all these 3 months. So we offered the patient a regenerative endotherapy because the tissue, the margins already were fibrotic, and clipping was a little bit difficult in this situation. And cost, as I said, this is pretty cost effective for patients who cannot afford OVESCO, etc. type of therapies. And once the fat is injected, and this is just 4 weeks later, 4 weeks later, we have seen that there has been complete closure, complete epithelialization of the tissue, and you can see on the follow-up barium as well, there is no residual leak left. So again, this is another indication of benign indication here. And one more situation are IBD fistulas. I think IBD, some of the fistulizing Crohn's are some of the most difficult cases. Even after surgery, these patients require a lot of interventions. This patient underwent 2 surgeries already and still has a persistent duodenocutaneous fistula. You can see the external indurated opening, the internal opening in the duodenum, and a long tortuous fistulous tract on fluoroscopy. And this patient again underwent endoscopic injection of the fat at the site of the fistula, and we also injected into the fistula as well in this patient. And can we show the, yes. So we can see in the video how the fat is being injected into the fistula, and this is just 4 weeks later. The external opening has completely closed, and internally also endoscopically there is a minimal residual sinus. If you can compare with the previous fluoroscopy, the present fluoro shows a complete healing of fistula except for a minimal residual opening. So even in IBD patients, where patient on biologicals who are refractory to biologicals, who have already undergone surgeries and still the fistula was persistent, and this regenerative endotherapy helped in healing of these fistulas. So this is a new avenue for us, and we have been seeing excellent results. We have done so far 50 plus cases using the regenerative endotherapy in the past 6 months now that we have started this program, and this is a really promising avenue for chronic GI fistulas. I'll be happy to take any questions if from the audience or from the
Gautam, a wonderful demonstration of newer technique. Few questions. Number one is, any contraindication of fistulas for this procedure?
Sir, no contraindications whatsoever, sir, because any chronic fistulas, we can attempt this procedure. But yes, what I would say is in infected collection, if this fistula is associated with an infected collection, like an abscess is associated, it is important that we drain this collection or we treat with antibiotics adequately before attempting to close with the fistula is number one. And one additional thing I would say for better healing, what we have noticed, especially in that case that we saw the rectovaginal fistula, this patient had already a sigmoidostomy. This patient already underwent a diversion procedure. So patients who have had a diversion procedure already usually benefit better with the treatment compared to the continuity. And even in patients with esophageal or duodenal fistulas, these patients, we advise them to be on nasojejunal feeds at least for a 3 to 4 week period until the healing happens, so that it improves the healing of the fistula. If you continue to take food, if the stool continues to pass at the fistula site, we have seen that the healing may take longer and they require more number of sessions compared to when you put them on nasojejunal or diversion procedures, sir.
Any complications post-injection?
No, sir. No major complications have been reported either in the literature or in our series as well. The minor things that we are worried about in this situation is the site of liposuction, because endoscopically the technique is very minimal. It's just an injection of the fat. But with the liposuction area, sometimes they can develop a small hematoma at the site of liposuction, and so we advise the patients to maintain a crepe bandage for at least 3 to 4 days, tight crepe bandages at the site of liposuction. And other than that, we haven't had any complications, and all these patients are discharged on the same day. The procedure is done as a daycare basis, and we discharge the patients on the same day, sir.
What size of injection you use?
We use a 19 gauge sclero needle because this is a stromal fraction. It is very thick. So 21 gauge needles or 25, it's impossible for the fat to be injected through them. So we use a 19 gauge sclerotherapy needles for injection.
And you have done more than 50 cases.
Yes.
Any cases you have faced failure in these 50 cases?
Yes, sir. We have seen around closure in around 70% of cases. Among the 50 cases that we have done, around 30% of patients we still had a failure. What we have observed is, as one concept is the continuity of the GI tract. If there is a continuity of the GI tract, stool coming into the rectum, stool coming into the sigmoid, those fistulas, there we had difficulty in closure. Other very active IBD disease. Sometimes even patients should have a the ulcer should be healed on the endoscopic side. If the patient are on biologicals and the mucosal healing is very good, then the success rate of this procedure is much higher. But if the ulcers are still present, very active, significant ulceration in the intestine, again there is a difficulty in closure of these patients. And the other case, one tracheoesophageal fistula, what we have seen is this patient had a bronchiectasis, the lung lobe has almost collapsed and there was recurrent LRTI. This patient also had a difficulty in closure, probably because of an active infection that has been going on in the bronchiectatic segment. So we believe active infection, very active ulcerated IBD and continuity of GI tract. These are the some of the situations where the closure has been a little bit difficult for us.
Excellent.
Thank you. Excellent.
Dr. Gautam, one more question. So, do you think that routine diversion is necessary for looking back regarding the failure of cases? So, do you think that diversion should be required for all the cases where you anticipate closure?
So, very good question, sir. So, I would probably put it in a different way. See, whenever we are introducing a newer therapy modality, any endoscopic closure modality, we need to understand this is something of a new avenue. So it is not established in the treatment protocols or treatment algorithms. We need more data to understand where to position it in the management of a fistula. So usually, for example, I'll give you the other day we had a elderly gentleman around 70-year-old who had a sigmoid diverticulitis and then developed a colocutaneous fistula. His ejection fraction was 25%, and he has recurrent VTs and he had to undergo an ICD. And these are the patients where surgery is like almost impossible. Ideally, this patient would probably undergo a sigmoidectomy because of the diverticulitis to prevent recurrent diverticulitis. So these are the cases where even we don't have a diversion, we can attempt to close the fistula. But diversion helps. We don't have enough evidence to just compare without diversion or with diversion to give a statement in this situation. But definitely diversion helps based upon the physiology that even in patients with IBD, even in the prolonged intracutaneous fistulas, our surgical colleagues also tell us that diversion itself can heal most of the patients. So diversion definitely helps, but whether it should be done mandatorily prior to the regenerative endotherapy is something of a question that we have yet to have answers.
Thank you. Also, do you recommend that we should use it as an adjunct to the clip closure, or do you want to use it in isolation?
So very good question once again. So adjunct therapies are definitely beneficial, especially if the fistula size is larger and if you can approximate the edges. So because that helps in faster healing. We have used adjunct with clips. We have used adjunct with APC. We have used adjunct with endovac therapies as well, wherein we reduce the infection. For example, there is a collection at the fistula. We do the endovac. We reduce the collection and then inject. Or sometimes if the fistula size is more than 8 mm, 1 centimeter, it is better to approximate so that the number of sessions needed for the healing will be lesser and there will be faster healing.
Gautam, would you like to extend your study for the fistula in NO also?
Yes, we have actually done. We have an ongoing study, but specifically we are doing in patients with IBD with refractory fistulas. We have not started a study so far in isolated perianal fistula. This is still, we are discussing the potential role of, especially in recurrent patients who develop recurrent fistula in ano without any IBD. There is a consideration, we had a discussion with our IBD colleagues as well, whether these recurrent patients should be considered a subset of IBD as well without any bubble involvement. So there is a lot of issues going on over there, but definitely, sir, that's an excellent suggestion. We are definitely looking into that to offer it to patients with recurrent fistula in ano.
I think it is much simpler for the fistula in ano because there is no bowel disease.
Correct. So that's
treating both bowel disease as well as fistula. Here you have to only tackle fistula. So perhaps
correct, sir.
Yes, sir.
So yes, I agree with you completely. But we have yet to venture into that space right now. So we will definitely look into that, sir. Thank you.
What is your hypothesis for mechanism? How does it work at molecular level?
Very excellent question, sir. So basically, chronic fistula, the pathophysiology of any fistula that doesn't heal. all these refractory cases, what we see is altered wound healing, where the wound healing is disturbed, where the wound doesn't heal as expected. So by injecting the mesenchymal stem cells and injecting these anti-inflammatory cytokines, growth factors which are noted in the stromal fraction, we induce the tissue over there into the normal wound healing process compared to the altered wound healing process. So this technology or the stromal fraction has been used for refractory cases by our other colleagues. For example, our plastic surgeons have been using it for a long period now. For chronic scars, for burns, ulcers, chronic non-healing ulcers, this adipocyte TSVF has been used probably for the last 2 decades now. And even orthopedics have been using for joint regeneration, where patients do not want to undergo the total replacement. This adipocyte TSVF has been used in these patients as well, and they demonstrated wound healing. So pathophysiologically, the altered wound healing which is noted in the chronic fistulas is kind of corrected to the natural wound healing or the correct wound healing process by which the regeneration and the epithelialization happens, by which the fistula closes.
Is there any study which you do, as you said, in an adjunct with the clip closure, with adjunct with any immunotherapy and this method also for IBDs?
So because this is a relatively new area, so far all the studies that have been published are all prospective single arm studies, sir. In the largest case cohort that has been published is in endoscopy on a 30 patients, 15 of esophageal and 15 rectal defects they have published. And here they have used endoscopic suturing is the only modality that they have used. They have not used any adjunct therapy. So we don't have enough data or enough cases to compare also to say which will work better. But definitely the concept is, if we can approximate it a little bit, then inject the SVF, then the healing is faster.
Thank you, Dr. Gautam, for the excellent demonstration. Thank you, Gautam. Thank you, Swapnika. We move on to next case where Dr. Asif is ready with another important domain for diagnosis of or rapid diagnosis of a common clinical problem. Dr. Asif and Dr. Rajendra Patel, you're on.
Yeah. Yeah, can you hear me now?
Yes.
Yeah. So this is again another interesting case which we are diagnosing it. This is a 31-year-old female patient, came with abdominal pain and weight loss for about few months. CT scan imaging was showing multiple lymph nodal masses and a large mass close to the head of pancreas, close to the porta. The large mass lesion was seen compressing the bile duct and also causing dilatation of CBD. So for want of time, I have put in a scope inside. I'm going into the D1 and just show you the mass lesion here.
So I think we'll be demonstrating endoscopic ultrasound actually, and we have a new endoscopic ultrasound machine where Dr. Asif will be showing about the diagnosis and then the evaluation of the lesion.
So what we are seeing here, can you see this? Can you see the EUS image?
Yes, we can see it.
Yeah. So I'll just put a pointer and show you. So this is a very large mass lesion close to the duodenum which we are seeing it. It's a very large mass lesion. Roughly about
You increase the brightness at your point.
You're not able to see the image?
It's little darker.
Okay. Can you increase the brightness? They're not able to see the US image. So this is okay. Maybe adjust penetration. Can you see now?
Yes, we can see it now.
Yes, now better.
Okay, so this is a large mass lesion seen in the paraduodenal mass lesion, probably replacing the head of pancreas. I am not able to see the head of pancreas. It is also narrowing the duodenum. What has happened is we can also see that the bile duct is also dilated. So if you see it from the stomach, I could see that the bile duct is dilated here grossly. So this is a bile duct which is dilated. You can see this is a bile duct, and there is a lymph node in the perihepatic region. You can see close to the common hepatic artery there is a large lymph node as well. So what I will do is I will first take a FNB from the mass lesion in the duodenum and also try to take that perihepatic lymph node FNB. So why I am doing is, we don't know whether it's a primary neoplastic lesion or it's a primary lymphatic lesion or a secondary metastatic lymph nodes.
Yeah, so I think
because the lesion in paradiurnal lesion is very large, so we're not able to make out whether this is a lymph nodal disease or it's a metastatic lymph nodal.
so I think we take FNA via I think different kinds of needle actually. So what needle I think we are using is 22 gauge Boston Scientific needle actually. It is called as acquire needle actually. So with
Okay.
this,
Yeah. Coming to the needles, what we are using is a FNB needle. So the gauge is 22 gauge needle. We prefer 22 gauge needle over anything else because it gives a better yield. And why we use FNB needle is it maintains the architecture, tissue architecture while taking an FNB. And this is a Francine tip needle. If you see the tip, can you show the tip of the needle?
Are you going to take it from the lymph node or from the mass?
I think we'll be taking from both the lymph node and
Both the lymph node and
the
the
mass. Yes.
So what I will do first now is, okay.
Yeah. Separately, we'll be taking in 2 different bottles.
The tip of the needle, if you see, this is a Francine tip needle. It has a crown-like appearance in the tip. Can you show that? White background. Yes. So the advantage with needle is we'll get a better tissue yield and the architecture is maintained. So I'll be putting this needle inside. Can you just so through the channel of the scope, I'll be inserting the needle. I'll fix the needle.
Dr. Asif, do you always use FNB for lymph nodes or large solid lesions, or you still feel that FNA may be useful sometimes?
Yeah, not most of the time we are preferring FNBs because as you know we get a better yield with the FNB needles, but sometimes FNA has a role. Sometimes if it is a slippery lymph node or if there is a lot of necrotic lymph node with pus and things, FNB needles may not be helpful. Even if it's a hard lymph node also sometimes FNA needles are very helpful. So this is a mass lesion. You can see that the arrow which I am showing, this is a mass lesion. What I will do is I will take one more pass here. The first pass here. What I did is I fixed the sheath of the needle and needle up to about 4 mm. So can you appreciate the needle tip here? If you can see this is a needle tip here. I am going to take it into the mass lesion. Doppler please. Before going into, I'll just check if there are any vessels. There are no major vessels there. Just
yes, now we can see.
I'm into the needle. You can see the needle, right? Clearly?
Yes.
Yeah. Yes. That's a needle. So I'm into the mass lesion. What I'll do is I'll do a door knocking method here. Door knocking method is fixing the needle stopper and then keep knocking over the mass lesion like this. You can see the sound also which comes. That's called a door knocking method. We get a better yield with this method. Another technique is a fanning technique where we use our knobs to just rotate the needles so that we can take all over the lesion like this. So these give a better yield of tissue. So what is important is asking the our technician to slowly pull the stillet. It's called as a slow pull technique. So by slowly pulling the stillet, when I keep going inside and out, we get a lot of tissue. So now I'll ask my technician to put it in the slides, this material which we have acquired. Yeah, it's okay.
How are the rate of complications you accept in USFNB?
So usually it's a very safest technique. We can say this FNB needles, though they are little thicker when compared to FNA needles, no major complications except for some minor bleeds which we can see. Sometimes if the patient has any coagulation abnormalities, then you see a little more bleeding. Otherwise, it's a very safe technique to do. Yes.
What you're seeing on screen is the smear preparation. That's very important. So we are lucky to have pathologist in the room to give us a rapid diagnosis.
So what we have done is we're making slides and we are also showing a rapid on-site examination here. Our pathologists are here. They'll be staining the slides and showing the histopathology. Can you focus on the slides and see the material? Either. Can you just focus on the slides and show the material?
You can see whitish material.
Yeah, we have gotten enough material in the slides.
So Dr. Swapna is here from the pathology.
The smears were spatched and they are fixed
Yeah,
here.
Dr. Swapna, can you please hold the mic closer?
Yeah.
Here we can see the good cellularity.
Yeah.
Now we'll process it and then later we can see what is there in the smears.
Okay. Okay.
Okay, great.
So,
So we wait for the moment.
ma'am is happy with the cellularity. So I think.
We are
So I
fixing
think
the
we have enough smears. So we'll be processing it. So we'll meanwhile I'll also show another lymph node where if you want.
So this is called Rose, Dr. Asif. You want to add more about it?
Yeah. Yeah, there's another lymph node here. You can see here close to the porta, the portal vein. It's also close to the hepatic artery. Can you see that? So this also will be taking FNB in due course. Probably it looks like an primary lymphatic disease. Probably we have adequate cell block. We need an adequate cell block here. With the FNB, what we get is we get high volume tissue so that molecular profiling, next generation sequencing and immunohistochemistry can also be done with this tissue.
Sir, can you tell us about the few station based examination actually? Just name the station based what we see in each area, because I think our audience is more of non-endoscopist actually.
Okay.
So I think US wise they might be, I think if they are aware of the station based examination.
Okay, what I'm seeing is from the place where I'm seeing is station 3 where I can see the proximal stomach or G junction. What I can see is a portal vein here, the left lobe of the liver, and we can also see a middle hepatic vein going across. So what we see at this station is we'll have to see portal vein, IVC, and then this is the IVC, and
yes.
then the aorta.
Aorta, yes.
So these are the three important base stations which we have to see in this area.
Yes.
And also a celiac takeoff.
Takeoff,
which you can
yes.
see here.
Yes.
So I'll meanwhile I'll do one pass on
Yes,
this.
yes. Lymph
this
node.
P.
Yes.
This is a second lymph node which we are taking. Please,
Yes.
Doppler, please. Oh, okay, we are safe now. There are no major vessels on the top.
I think in US not only we do diagnostic procedures, also we do a lot of other therapeutic maneuvers actually. Also we have advanced imaging techniques like elastography and seeing the increased vascularity, SMI technique, and there are other things what we do in US actually. So it has gone beyond diagnostic evaluation actually, to measure HVPG, to do cystogastrostomy, to drain a cystic lesion, or to put a stent in inoperable cases and all actually. And there are a lot of therapeutic advances that has happened in US.
So this is very useful not only in diagnosis, also in therapeutics, as Rajendra said. This new processor also has multiple other functions like 3D imaging and other panoramic view.
So what I think the processor we are using is Aplio i800, that is from the Olympus actually.
Yeah, what we can see here, can you see this? This is a new processor where we can also identify the vascularity. What we can see is this, the entire vascularity can be seen over the mass lesion. We do not give a contrast imaging so that it gives us whether this is a solid tumor or it could be a neuroendocrine tumor. We can differentiate multiple other things.
Yeah. So if anybody has any questions, we can take up the questions.
Rajendra.
Yes.
So I think we are disconnected. So maybe you can continue. Yeah, just now we got disconnected. They are trying to connect back. That's why there are no questions from there.
Okay. Okay.
Yeah. No problem. We can go ahead with the pathology processing.
Okay.
So once they are ready, we'll show it to them.
Okay. Okay.
Fine. If VPNL is fine. One more pass.
Asif sir, we are moving to Anudeep.
Yes.
Yeah. But
Okay.
still there is no connection. Anudeep.
Okay.
Anudeep, we are, you are on
Connection आते ही
screen.
बताओ sir.
Yeah, you are on screen, but they are not connected.
Connection आता ही बताओ, wait करेंगे.
Anudeep, we can go ahead with the polypectomy. Actually, they are taking time. The entire hall is disconnected. They have communicated that we can close the session. After this, Dr. G.V. Rao sir's talk is there directly
Okay.
at 1 o'clock. So they are communicating right now also.
अम्मा इधर पकड़ना.
Sir, we go ahead with polypectomy, sir.
Anudeep, go
Good afternoon, GV. How are you?
Thank you. Can you hear me?
Yeah. I'm actually very close to you. I think I'm the closest I'm actually en route to Indore. I'm in Hyderabad airport. That's why I couldn't be in Berhampur. But I'm watching silently your team doing wonderful work today. Whether the parliament passed the women's bill or not, there is quite a good women's representation from the performance from AIG. Really very heartening to see that, GV. Four people nicely demonstrated all the cases, and we have a good audience.
No, thank
Goindraj
you
and
so much actually for
yeah.
all this, Ishwar. Actually, it's not possible because for all the support that IAGS gives us, actually, we are ever grateful, ever obliged to you.
We need to thank you. And actually, we are now coming out. I don't know whether you've been given invitation to come us in Kalaivani from Bangalore. Might have invited you. We have a midterm conference IAGS in last week of June, where actually we wanted to have a program of endoscopy, and we may be contacting you. If not already, if she hasn't done. Govindraj, myself, we were on the talk to have some
Yes,
representation.
certainly. Let me know. Yeah,
Please.
no problem. Just let me know the dates actually, then I'll see you best we can.
Yeah, it is 25, 26, 27, June last week, but we'll let you know. And
All right,
really,
sure.
we enjoyed this nearly 2.5 hours of non-stop endoscopic extravaganza. Nicely demonstrated, and because we could only show some basic cases yesterday, but really it complements whatever they learned today. And I think you are doing a great service along with us to all our surgical junior colleagues to take up this skill set in a big way. So we have,
Yeah,
so
because
that
unless
is
and until they know what is happening, they'll not venture into new things actually. And most of the things can be duplicated in 2-tier, 3-tier cities also. It is not that it is restricted to only advanced centers. As
Yes.
long as they get the proper exposure to the thing, I think they should be able to do it, Ishwar. I think that's the best part of it. Actually.
Yeah. Thank
And
you.
your service
And
is commendable actually to see to get these people connected. See, you understand actually that is persistently you've been
yes.
doing it for so many years.
Yeah.
That is
That's
what
all the
is
motivation we get from you and Nagi. Actually, I wanted to, while we are waiting for them to connect, I just want to ask you. Actually, we are coming out in IAGS ERCP simplified. There is a small theme
yeah.
where, because already we have done 3 courses of ERCP, 4G ERCP in Rajamundry in GSL, and also once
Yeah.
we wanted to have a 120-page manual, and the last chapter of the manual is the experts column. So wherein we'll have something like a panel discussion with you, myself, Govindraj, and Amit Madio, people and we'll discuss. And the questions are attuned to those people who are trying to take up the ERCP, and from surgeon's perspective. And whatever you say, we'll put it in AA, then we'll put it as a chapter, experts column, it's a
No problem.
consolidation of all the 12 chapters we have written, like 1 or 2 questions, where rather than us giving our own opinion, it's experts on the field in India, what they feel, like where they pre-cut, when and how. Then you or Amit will be answering. And like that, I framed 30 questions. And that is the best way I thought we'll assemble you and make it as a chapter. This book most likely will be released in the midterm conference. That's why I wanted to see where in your presence. I'll be in touch with you shortly. But while you're there, I thought I'll discuss with you
No
the
problem. No
concept and
problem.
things. Thank
Oh,
you. Thank you very much.
no problem.
Thank you. I think following your speech is going to be inauguration. I don't know whether they have any challenge in the hall.
Let's see, Ishwar, if there's any challenge, you can always cut it off actually. But if they're able to connect,
No, no,
I'll
no.
continue.
I'll talk to them and get back to
Yeah,
you.
no problem.
JB.
I'm online.
Yeah. Thank you. Thank you very much.
Bye.
Thank you.
Yeah, Govindra. Yeah. Uh-huh. Yeah, no problem. Just let me know what time. Actually, I'm in. Yeah, that should be okay. Let me know. Right. No problem. No problem. Oh, it's right.
training with a fellowship in GI surgery from the prestigious Sir Gangaram Hospital, New Delhi. Adding to his distinguished academic journey, he was awarded a WHO fellowship in GI oncology from the renowned Kidwai Memorial Institute of Oncology, Bangalore. With extensive training and expertise in GI surgery and oncology, he brings with him a wealth of knowledge and experience. We welcome you to the dais, sir.
Now I'm going to introduce the next distinguished speaker, Dr. Satish Midha sir. He is highly accomplished laparoscopic and gastrointestinal surgeon from practicing currently at Vivekananda Hospital, Ranchi. He is the former chairman of ASI Jharkhand, former president of IAGS and former national president of NMO. We warmly welcome you, sir, to the dais to chair the next session.
Next, I would like to introduce and invite Dr. Charan Panda sir. Sir is an accomplished advanced laparoscopic and general surgeon known for his extensive clinical experience and dedication to surgical practice. He completed his MBBS and MS in general surgery from MKCG Medical College, Berhampur, and went on to join the same institution in 1996 as an assistant professor, contributing significantly to surgical introduction, education and training. He also serves as the chairman of the Silk City Surgeons Club, Berhampur, reflecting his active role in this local surgical community. We're honored to have him with us today. May I now invite him to the dais.
Next, I'm going to invite Dr. Satyapriya Sarkar sir to chair this segment. Sir has been examiner and teacher for EFIAGES, FAGI for 13 years and has played a pivotal role in training and mentoring surgeons in endoscopy. With his extensive contribution to surgical education and endoscopy, we are truly honored to have him with us. May I invite him to kindly grace the stage for next segment.
It's my pleasure to introduce our next distinguished speaker, Dr. K. Govindat sir. He holds an impressive array of international qualifications including MS, FRCS from Glasgow and Edinburgh, FACS, FIAGS, FICS, EFIAGS, FAGIE, along with diplomas in laparoscopy from Germany and MIS from France. He is a highly accomplished consultant in endoscopic, laparoscopy, and laser surgery, known for his expertise and innovation in his field. He currently serves as the chairman of Dr. G. Vishwanatham Specialty Hospitals Private Limited, where he continues to contribute to excellence in surgical care. We are truly honored to have him with us today. May I now invite him to kindly take the stage and share his valuable insights on the topic. Thank you, sir.
Thank you very much for your introduction. And yep. Thank you. Our past president, Dr. Satish Midha sir, and my dear friend and my elder brother, Dr. Satyapriyo, and from the Department of General Surgery, Dr. Patnaik sir and Dr. Panda sir, and my colleague of IAGS, Dr. Vijay Bogrankar from Aurangabad, and all the delegates. I should thank Dr. Madhuri Patnaik for arranging this event. If not for this, I would not have been in Berhampur. And it was so nice, a warm hospitality and a warm welcome that was applauded me to when I landed in Bhubaneswar. Thank you very much. And I'm going to give series of 3 talks. My first talk will be on ABC of ERCP. So I think it's going to be a basics, EFIAGES is going to be basics, but still you need to learn what else you can do in ERCP. So what is ERCP? ERCP, I think most of you know what is ERCP. ERCP is nothing but endoscopic retrograde cholangiopancreatography, where you do lot of endoscopy to treat bile duct strictures, benign, malignant, and of course stones in the CBD and the cystic duct. And in fact, intrahepatic biliary stones also you treat this way. And the very important point which I have to underline here, there is no role for diagnostic ERCP in today's world. I think by 1995 itself, the role for diagnostic ERCP has been taken away after the advent of MRCP. So this is the basic anatomy in which we are going to tread upon for this ERCP here. as you all know, what we talk about is the hepatobiliary tree here. And to little bit into the history of ERCP. It was developed in 1968 as a diagnostic tool. You have to remember 2-3 people. One is Dr. William McCune. He was basically an obstetrician who did the first ERCP using a fiber optic duodenoscope and a balloon to cannulate. Then in 1972, Dr. Peter Cotton described the cannulation. Then Dr. Reinhard Claassen, from Germany, and Kawai from Japan simultaneously did the first sphincterotomy. They did at the same year, they did the first sphincterotomy. So these are the few people who are the fathers who started ERCP. The indication of ERCP today are biliary stones, pancreatic duct stones, calculus pancreatitis, iatrogenic bile duct injuries, malignancy, particularly periampullary carcinoma, cholangiocarcinoma, and Klatskin tumor. Here, if you look at this iatrogenic biliary injuries are the most interesting topic as a surgeon, where ERCP comes to play an important role post laparoscopic cholecystectomy injuries. Preparation of a patient before ERCP. The upper GI tract should be empty. Generally, no eating or drinking previously for 8 hours. Smoking and chewing of gum should be prohibited. Current medications may be adjusted or avoided, and medications can be continued as usual post ERCP. Removal of any dentures, jewelry, contact lenses, these are all the basics of endoscopy, particularly any therapeutic endoscopy. Before ERCP, all the patients' previous abdominal imaging findings, MRCP, CT, ultrasonography should be reviewed before you start an ERCP. And these are the basic things which you need when you do an ERCP. What is TIVA? TIVA is a transient intravenous anesthesia. And what is BIS? BIS is bispectral index. These two things play a major role when you give anesthesia, and most of the ERCP are done under general anesthesia. Sometimes it is intubated, most of the times it is under TIVA. TIVA you don't intubate, and these are the bispectral index is the BIS scoring. You generally try to have the BIS scoring, the bispectral index around 60 to 70, that the patient is under life sedation. This is how you do an ERCP. And ERCP accessories. What are the basic accessories? ERCP cannula. You look at this tip, there are 2 tips there. These are the 2 tips which you commonly have a cannula. This usage of the ERCP cannula is gradually coming down because most of the ERCP fellows who do it use a sphincterotome instead of a cannula here. Then the cannulating devices is called the sphincterotome. This is a sphincterotome here. You see here in the first one, you see a wire there. It's similar to a cannula with a wire in between like a bow. So this is called a sphincterotome, where you cut the ampulla in this way. So this is an ultratome. The soft tip is less trauma, where you have 7 French to 5.5 French. And the second one is called a steerable sphincterotome. So you can steer the sphincterotome either from 11 o'clock position or to a 2 o'clock position by using this steerable sphincterotome. The true tome, there is another company called which makes a true tome. It is merging the lumen technology, central contrast avoids a pancreatitis. That means that which is steerable, and you can have the handle which can break free and easily it can be used by a technician. This is a new thing called the true tome which is happening now. Then the next instrument which you commonly use in the ERCP is called the needle knife. The needle knife I have seen in my practices in the last 35 years. Surgeons use more needle knife than a medical GI. I don't know why, but we are used to knives, that's the reason I think. This needle knife, as I said, in the needle knife, this will not have a wire there. There will be just a knife there at the end of the tip here. And when you are not able to cannulate a sphincterotome to do a sphincterotomy, you do a pre-cut. That is, you cut the ampulla using this needle knife. That is called the needle knife. It's called a micro knife XL. That can be controlled from 1 millimeter up to 6 millimeter. And there are visual markers in the needle knife. You can see there is a blue, red, and a green there. And these visual markers are used to control the depth of the knife in which you go into the ampulla. And there are various types of guide wires which you see here. The first one is called the jag wire, and the jag wire is this one which you have different colors like the black and the yellow, and in the tip of the jag wire you have a wire that is very flexible. This is called a jag wire here, and the guide wire are all made of nitinol, which has a thermo tip. This black tip which you call here, see here, is called the thermo tip. And this jag wire, which is 5 centimeter hydrophilic tip, and the kink resistant shaft, that is the shaft you cannot kink it when you get out of the ampulla, or when you get out of the sphincterotome, the kinking resistance is very high there. This is a tungsten filled tip. This tip is called a tungsten filled. There is another wire called the dream wire. This is 10 centimeter dream tip. The end is around 10 centimeter, and 3 centimeter in the tip is floppy tip, and which has got a gradual tapering there. For very difficult cannulations, we use this dream wire, and when you push it inside very tight strictures, the pushability is much better in this dream wire, particularly when used for tight strictures. So these are the various types of wires which you use for cannulation. The accessories which you use for CBD stone management are: one, this is the CRE balloon. Here, this is the first one, is called the CRE balloon, and the procedures you do here is the DASE, DASE, that is dilatation assisted stone extraction, is called DASE. Then you have the basket called the trapezoid basket, and what we do with the trapezoid basket is you put the basket into the CBD, you catch the stone in that, and using the trapezoid basket you can crush the stone. That is called as trapezoid basket. And there is another procedure called the BASE. It's called balloon assisted stone extraction. DASE is dilatation assisted stone extraction, and BASE is balloon assisted stone extraction. And these materials which are used for this balloon are PBEX material, which is a non-compliant but multi-diameter material. So this CRE balloon is a continuous radiation balloon where you can expand the same size of the balloon for dilatation, right from 8 millimeter up to 11 millimeter. You can do 3 sized gradual dilatation we can do with this. And in this trapezoid, this is called a silver tip technology. The tip is silver coated, and the tip disengages and avoids the basket impaction, and the nitinol wires smart memory and cuts through the stones. Here you can see these nitinol wires which has got a smart memory. You have different size of baskets there, and the wire guided is for better position. You can see a wire here. You put in a wire into the CBD, over the wire you pass this trapezoid and then catch the stone and crush the stone. And these are the two ways in which you capture a stone. And here you can see a device on the right hand down corner. That is a device which is used to inflate the balloon. This technology which I use here is called the BASE, balloon assisted stone extraction. Here I use this balloon device. You fill up the balloon device, inflate the balloon device, and then pull the stone. It's called trolling of the stone. You remove the stone along with the balloon inflated to the proximal part of the stone in the CBD. Here you can see stone balloon extraction. See, you got the stone balloon extraction, you got the tips of the balloon here. This is called a square shoulder. The shoulder is squared, which avoids slippage of the stone. The stone doesn't slip. More latex, this is more latex than the dilatation balloon. So there is very better durable. It doesn't break with the stones there. And injection below the CBD lavage. That what happens is, when you have this portion is there, you can do a CBD lavage when you do the stone extraction also. And basket for stone retrieval. This is what I told, trapezoid basket, and with the wire guided memory, the basket can be guided through the wire there. Lithotripsy, and there are various types of lithotripsy there. This lithotripsy is the device which I initially told, which was the trapezoid, and this one is called an EHL or electrohydraulic lithotripsy, the bottom one in the left corner, and the middle one is called the Sohendra lithotripter. This is a very important device in any therapeutic endoscopy unit you should have, the middle one, the black one, because this was invented by Dr. Nib Sohendra. Dr. Nib Sohendra was an Indonesian who moved to Hamburg, and he holds the position of the head of the department of the Hamburg University, and he has invented a lot of guide wires. He had invented sphincterotomes, and he did the first sphincteroplasty, and this is invented by Nib Sohendra. The advantage of this lithotripsy is, when you put a basket inside the CBD and you want to capture the stone, sometimes the basket can cut. Then what happens is, the distal part of the basket is in your endoscope and the cut portion is with the stone in the CBD. Then if you don't have this device, then you will have to open up, remove the basket by you doing a CBD exploration. If you have this device, you can put this device to the distal tip of the basket, you can cut the stone, either the stone will get cut or the basket will get cut, and you can remove the basket. So this is a very important device when you start ERCP to have in your unit. Dilatation and stenting devices. This is called a CBD dilatator. This is a CBD dilator, as I mentioned earlier, that was a balloon dilator. This is a graduated CBD dilator. It is similar to the Savary-Gillard dilator which you have for esophagus. Here you dilate up to 3 sizes. This dilator comes in 3 sizes. You start from 6 French, 7 French, 8 French, then you go up to 10 French. These are the dilators which have sizes, and this is the CRE balloon. And this CRE balloon also you can dilate with a single balloon up to 3 sizes. So these two are the dilators which we commonly use in CBD. And biliary dilatation balloon and cytology brush. This is the first one is called the hurricane balloon. This is from a company called Microvasive. This is called a hurricane balloon. The fluoro markers on the catheter are better for fluoro positioning. Under C-arm, you keep this balloon and you know where the stricture is to dilate this balloon. And then the metal stillet, better pushability. You have a metal stillet in the tip. It is for pushability of the balloon into a tight spot where there is a stricture is. And the balloon diameter extends from 4 millimeter up to 10 millimeter in size. It is usually 3 size graduation. Balloon length is around, this length is around 2 centimeters to 4 centimeters. And what I say about the cytology brushes, when you have a tight stricture, you always do a brush cytology and take up for histopathological advantage. There are units nowadays which have the histopathological unit side by to the endoscopic lab. So when you do the endoscopy, you take a cytology brush, you can know the diagnosis whether it is malignant or benign within half an hour. Biliary and pancreatic stents. These are the various types of biliary stents which you see here. Each stent has got a different name, and these are the pancreatic stents here. Usually the biliary stents starts from 6 French up to 10 French. These are the common sizes which you use a biliary stent here, and the pancreatic stent starts from 3 French up to 5 French. So pancreatic stents are below 6 and biliary stents are above 6. And stent pusher. Once you put in a stent, then you pass a stent over a guide wire. You use a device called the stent pusher. The stent pusher device varies from size from 5 French to 10 French here. Here you see there at the tip of the stent pusher, it is always flat. It is not tapered. It is always flat to push the stent inside the CBD or into the pancreatic duct. And if you see here, proximal to the tip, at least 1 centimeter above, there will be a guide wire there. That will be a wire which is fluoro positive there, and this is the one which keeps the tensile strength of the guide pusher to push the stent into the CBD. Various types of self-expandable metallic stents are there. These are made of materials called nitinol. So this is a totally uncovered stent in the first one, and this one is a semi-covered stent or a partially covered stent in the middle one, and the last one is the fully covered stent. These are the 3 different types of stents which are being used. If you look at the usage of the fully covered stent, for benign strictures of the CBD, you always use a fully covered stent. The advantage is fully covered stent can be removed from a period of 3 months to 6 months. The uncovered stent or the partially covered stents are generally used for malignant strictures. So these stents cannot be removed after a period of 3 months. So if you need to remove this partially covered stent, you have to remove it within 3 months. After 3 months, it becomes very difficult, it's almost impossible to remove these stents. ERCP, different types of stents from different companies are. The self-expandable metallic stent is 6 French in size, and they are basically, they have this tantalum radiopaque marker at the distal and the proximal end. You can see in the middle here, the middle stent, there is a small roundish the marker there. That's called the tantalum marker. So when the stent expands, you always do it under fluoroscopy guidance. This marker is used to keep the stent distal to the stricture and proximal to the stricture. So you have these markers both at the proximal end and the distal part of the stent. So the stent covers the entire length of the stricture. Suppose the stricture is around 2 centimeter length, you have to use minimum of 4 to 6 centimeter length stent you have to use. These are the basic things which you do a stenting to be done. Devices aiding in diagnostics are the wire guided biopsy forceps.
See, when it's very difficult to do a biopsy, when it's a tight stricture there, you can put a guide wire. It improves the diagnostic capabilities and leads to increased sensitivity during ERCP procedures to aid in more accurate diagnosis. So, when there's a tight stricture, you will not be able to put the biopsy forceps inside. Under guide wire, you can do a biopsy, and the diagnosis is much more, and the yield is also much more. And cytology brush, which I said earlier, there are two types of cytology brush. This is the double cytology brush, this is a single cytology brush. These cytology brushes are always used over a guide wire. And the fluoro marker is at the tip of the brush. You can see there is a fluoro marker here, and the bristles are at an angle of 65 degrees. From the brush, from the cannula, it's at a 65-degree angle here, and it's always wire guided. The procedure. The patients always, they lie in a prone position. It's very rarely we do in a supine position also. Then the duodenoscope is inserted through the mouth guard, down the esophagus into the stomach. As you see in the end viewing scope, you see what you are looking at, and you are seeing and then going. It's like driving a car. Here I say in ERCP is like driving a car. You drive the car on the road, but you are watching through the window of the car. It's the same way you do an ERCP here. And the sphincterotome, which is inserted, because previously we used to use a cannula. Nowadays we use the sphincterotome to cannulate, and once you cannulate into the CBD, then through a guide wire, you check on a C-arm machine, you check whether the guide wire has passed into the CBD or the pancreatic duct. How do you identify whether the guide wire has passed into the pancreatic duct? When the guide wire passes across the spine, it is into the pancreatic duct. When the guide wire goes parallel to the spine, it is into the CBD. So once you are sure that it is into the CBD, then you do a sphincterotomy. And then you do a sphincterotomy, you make sure that you cut only the ampulla. You don't cut beyond the ampulla in that. And then the other procedures associated with ERCP include trawling of the common bile duct with the basket, as I said, or a balloon to pull out the stones. And then the pancreatic duct can also be cannulated and stented in case of pancreatitis when you have wrongly cannulated the pancreas. You want to cannulate the CBD, but unfortunately you have cannulated the pancreas. If that happens for more than 2 times, I always make it a point to cannulate the pancreatic duct to avoid post-ERCP pancreatitis. The techniques used in ERCP are needle papillotomy or sphincterotomy. When you cannot do a sphincterotomy, do a needle papillotomy, stone removal, stent placement for biliary and pancreatic drainage, balloon dilation, tissue sampling, and cholangioscopy or pancreatoscopy. And these are the 2 videos which I want to show here. What is sphincterotomy, what is needle papillotomy. Here, that is what you see on that image is called the sphincterotomy. I am cutting with the sphincter there. Here I am using a needle knife. I am cutting the ampulla alone because needle knife is not wire guided. The needle knife is blunt. So you should have very good accuracy when you want to cut here. See, you have to make sure the cut is along the 12 o'clock to 11 o'clock position. This is where the CBD enters. And there you are doing with the guide wire. It is very easy to control there. And here this is a fluoroscopy image of a common bile duct stone. You can see there, that's a common bile duct stone there. I have put in a guide wire there. I will try to get the balloon above the common bile duct stone and do a balloon trawling of this stone there. And this is this is a fluoroscopy image, dilated pancreatic duct. You can see the pancreatic duct which is dilated there. And when you have a chain of lake appearance, there is no role for ERCP in a chain of lake appearance because you will not be able to get the stones which are distal part of the pancreatic duct. So the duct should be dilated fully like this. The entire length of the duct should be dilated to get the stones out of the pancreatic duct there. And this is ERCP in a Mirisi syndrome. See here, as you saw in the morning, they were showing in US. Here in the US, you can see the stone there, which is a stone from the cystic duct. It is entering into the CBD there. It is from the cystic duct, it is entering to the CBD, which is causing compression of the CBD there. See, I am doing an ERCP there, and the stone I am able to retrieve here completely. In N block, I am able to retrieve this. This is a ERCP for a Mirisi syndrome here, which is being done. This is basket extraction of the CBD stone, which is being done. and ARCP in periampullary growth. Here you can see here, it is a huge periampullary growth here. Then what I do when I have such a big periampullary growth, usually I use a needle papilla. Here I do a needle papillotomy. I have put in a guide wire here, and through the guide wire I am putting a plastic stent. This case was being taken up for an Whipple's procedure, laparoscopic Whipple's. So we put in a plastic stent. We brought down the jaundice from 18 to 3 and then took up the case for Whipple's procedure. Post-operative care. The patients are monitored for the first 4 hours in an ICU, and once the sedative effects are over and all the vitals are normal, if you don't anticipate any kind of a pancreatitis, then you can shift the patient to the ward. And usually the patients are kept for 24 hours in the hospital before we discharge, because you have to look for pancreatitis. And oral is usually allowed after 6 hours, and amylase levels are always checked post-op in our center, particularly if the cannulation has been difficult, or inadvertently if you have cannulated the pancreatic duct trying to cannulate the CBD, you always check for the amylase level post-operatively. And in our setup, we always use a rectal diclofenac whenever you anticipate a post-op pancreatitis. Cholangioscope. Cholangioscope has been there for the last 3 decades, but the evolution of the cholangioscope from the initial mother-baby scope, now it has become a spyglass scope or spyglass DS cholangioscope. And this is nothing but you pass a scope along the biopsy channel of the duodenoscope and enter the CBD, and then look into the CBD. In case there is a stone, you do a laser or a EHL and remove the stone, or if there is a growth, you take a biopsy and then remove the stone. And spyglass DS, the therapeutic channel is used for passing the accessories through the DS scope here. You can see here. And you have a 4-way steerable catheter. That is, you can see here, there is the small wheel and the big wheel like in any other scope there. The working channel size of the spyglass scope is 1.2 mm. It is 1. These are the accessories. Basically similar to ERCP, you have got a snare here, you have got baskets here. These are basically spyglass accessories which are used inside the CBD. The spyglass forceps, which is a 1 mm cup size, which is an opening diameter, and spy retrieval basket, which is 15 mm opening diameter size, spy retrieval snare, which is 9 mm in size. These are the sizes of the spy scope accessories. And the laser which we use for spy scope is called the holmium laser. It is used for lithotripsy under direct vision, and the length varies from 200 mm to 500 mm, that is 500 millimeters. The frequency setting in which I use the holmium laser is 10 Hertz to 0.6 to 1 joule I use in this the spyglass. And EHL, when spyglass is not available, we can use EHL also. The size is 1.9 French. The size of this is 1.9 French. It is around 375 centimeters in length. The EHL probe was optimized for the use of spyglass DS scope. Direct visualization of the stone is done, and then you do an EHL. The proximal portion of the probe is reinforced and designed to prevent probe kinking in this. Here I am showing a video of a spyglass. A laser lithotripsy is being done. I am doing that is a pancreatic scopy, and this is a CBD stone. That is a pancreatic stone. I am using a holmium laser. Both sides I am using a holmium laser. That's a pancreatic duct stone. You can see the whitish color. I do a holmium laserization, pulverize the stone. Then I put in a 5 French stent in that case. Here the stone is in the right hepatic duct. I am using a dusting technique. Once I use the dusting technique, the stone gets entirely pulverized in the right hepatic duct, and I put in a stent into the right hepatic duct and then remove the stone fragments from there. The complications of spyglass are the ERCP and ERCP are ERP highly specialized and requires lot of experience and skill. The procedure is quite safe, associated, very low risk when it's performed by experts, and the rate of success rate in this procedure is 70 to 90%. Complications can occur approximately 1 to 5% depending on the skill of the physician and the underlying disorder. The significant risks associated with ERCP are infection, pancreatitis, allergic reactions due to sedatives, excessive bleeding can occur, puncture of the GI tract, that is perforation, can happen. Very rarely death can also happen post ERCP. The contraindications are unstable cardiopulmonary status, structural abnormalities of the esophagus, stomach or small intestine, which would be relative contraindication, altered structure anatomy, that is particularly Roux-en-Y has been done, And ERCP sphincterotomy is relatively contraindicated in patients with coagulation disorders. Thank you very much for your patient listening. If there are any doubts, I'm willing to answer here. Yeah, they will not waste time. We will go to the next session there. Okay. Thank you very much.
Hello.
Yes. Hello.
Thank you so much,
Hello.
sir, for this insightful talk. Now it's my pleasure to introduce our
Hello.
next.
Hello, please unmute. Please allow the transmission. Yes, you're on the line. Please unmute and start. They're showing you are muted. If you please
Hello,
unmute.
Dr. G.V. Rao.
Can you hear us? I'm Dr. Shatyapriya, Dr. Satish Midha, Dr. Govindaraj, our president, Dr. Bijay Burgaonkar, all are here. So please unmute and
Hi,
start.
can you hear me?
Yes,
now we can hear
please,
you.
please start. We are sorry for all the delays and others. Please start.
No.
It is my pleasure to introduce our next distinguished speaker, Dr. G.V. Rao. He completed his MBBS from Osmania Medical College, Hyderabad, and pursued his MS in General Surgery from Bangalore Medical College. He further specialized in laparoscopic and GI surgery from the prestigious Prince of Wales Hospital, Hong Kong. He currently serves as the Director and Chief of GI and Minimally Access Surgery and is also the Chief of DNB Surgical Gastroenterology, reflecting his leadership in both clinical practice and academic training. We are truly honored to have him with us today online. May I invite him to share his valuable thoughts on the topic endoscopic rescue of surgical complication. Thank you.
Good afternoon, Dr. Rao. I am Dr. Satish Midha here. So Dr. G.V. Rao is my mentor guru, and he has trained many people like us. And recently, with recognizing his contribution, the Government of India has awarded Padma Shri to him. And he is also inventor of many procedures, including notes. So he has brought India with Dr. Reddy into the world map of GI surgery and gastroenterology. Over to Dr. G.V. Rao for his topic on how surgeons can be rescued by endoscopy.
Satish, sorry, I thought the topic was surgery for endoscopic complications. Okay. Can you hear me, Satish?
Yes,
Please
we
go
all
ahead.
hear you, please.
Yeah. I thought the topic was surgery for endoscopic complications.
Yeah.
I know this is right.
Yeah,
Thank you.
please.
Now, GI endoscopy has evolved from diagnostic to a very powerful therapeutic tool, and recent advances have diversified treatment as an alternative option to conventional surgery. Consequently, when you're extrapolating surgical science, the emerging complications that happen during endoscopic procedure
Have you
need
shared
to
your
be
slides?
addressed. Are you not able to see this?
No, we cannot see. We can see you only.
I'm sorry. One second.
Just share the slides, please. We can see the AIG you have building and your face. And can hear you also nicely.
Can you allow the sharing?
Yes. Anything to do from our part?
No.
Yes,
Now we
start.
can see
Done.
that.
Done. We can see now.
Yeah, please go ahead. Now you can just full screen.
Yes.
Yeah.
Now we can see.
Yeah, please go ahead.
Yes.
So these endoscopic complications are either iatrogenic complications or sepsis-related complications that can be managed surgically. GI endoscopy perforations can happen in esophagus, stomach, duodenum, small bowel or large bowel. Now, these could be secondary to endoscope, the accessories that we use during procedures, the thermal energies that are used during the procedures, or the stents that are put in during various procedures. Now, there are several myths and realities regarding endoscopic complications actually. Now, endoscopic complications does not always mean that we have endoscopic solutions. Actually, it is not that every endoscopic complications can be treated by endoscopy. Second, endoscopic complications also does not mean they require surgery or every time. Surgery not always means open surgery because we have laparoscopy and robotic surgical options as in today. And unfit for surgery is patient is unfit for endoscopy. Actually, a lot of times, actually, we keep saying a lot of people that the patients are being taken up for endoscopy procedure because the patient is unfit for surgical procedure. Majority of the advanced GI endoscopy procedures are done under sedation or general anesthesia like surgery. So if the patient is unfit for surgery, the patient is also unfit for endoscopic procedures. The gap between the endoscopist and the surgeon has dramatically shortened. Actually, there were times when people were purely practicing endoscopy and surgeons were practicing purely surgery. But this gap between the surgeon and the endoscopist has completely changed, and now we see most of the surgeons practicing endoscopy, and most of the surgeons we see also doing very advanced surgical procedures. When we started our practice, when endoscopy came in a big way, people thought the endoscopists who's doing these procedures can completely replace surgeon in many ways. This was a cartoon that was circulated many a times in many conferences when endoscopic procedures became successful. The second myth is that surgery is the last option to treat endoscopic complication. Now you have an iatrogenic complication, you have statements and guidelines in which we say that patient is treated conservatively, pharmacotherapy, endoscopy, intervention, radiology. And if the patient fails all these things, the patient is taken up surgery. Now, the positioning of the intervention of surgery in these algorithms determines the outcome. If the patient requires surgery and the patient is going on conservative pharmacotherapy, endoscopy, obviously the morbidity, mortality will decrease. So, with expertise and wisdom, we need to position the surgical option in this flow diagram so that the patient is treated optimally and the overall morbidity, mortality is reduced. The therapy of the endoscopic iatrogenic perforation depends on the type, the size, the timing of diagnosis, whether it is done intra or post-procedural, is a clean or contaminated perforation, patient's general status, availability of closure devices or expertise, and endoscopist X versus endoscopist Y. Not all endoscopists are same. Some people have good expertise, some people don't have the expertise. It does not mean that you see one procedure, you can be doing that procedure. So you need to get trained in this procedure to make sure that you effectively translate this into clinical practice. Now, surgery is done when we have failed endoscopic closure or the patient's general condition is deteriorating in spite of the endoscopic closure device. There are several endoscopic options available right now. From through the scope clips, they're called TTS clips, or over the scope clips, they're OTS clips. There are self-expandable metallic stents that can be used to bridge the perforations. Endoscopic suturing devices are available right now. Umpteen number of devices have come, and of late Olympus has come out with a new suture, a needle holder which is similar to the laparoscopic needle holder, which can be used for suturing. Biological glue can be used. Vacuum therapy can be used for some of these procedures. Now, majority of the evidence is coming from retrospective evidence. Currently, available prospective outcome studies are very, very limited. And we should also understand that endoscopic clips are not equivalent to surgical sutures or surgical staplers. I think basically we should keep in mind that these basic rules and use these clips on the endoscopy side very diligently and use your wisdom to use wherever they can be used and wherever you think that can be securely closed. The clinical success of these clips, especially in esophageal perforation, the clinical success is about 85%. Now, failure mainly happens when the defect is more than 2 centimeters, or if you're trying to close perforation more than 72 hours after the perforation has occurred, basically because the edges become soggy and the clips cut through the, whenever you apply the clips, it cuts through the thing. Classical example, I'll just give you some example. This is a patient who underwent endoscopy. A junior was trying, and you can see this is a pharyngeal injury that happened. So you don't think this cannot happen. This is a large pharyngeal injury. It was taken up for surgery immediately, and then we're just trying to suture this pharyngeal tear under endoscopic vision. It is not that it has to be done, but just to show you how big the pharyngeal injury was and how endoscopy can be used to make sure that you have a good secure closure. At the end of the thing, actually, whenever we have this intraoperative endoscopy, it is used not only to check the integrity of the closure, but also to check for any leaks that happen. Intraoperatively, we can insufflate, inject some saline if it happens, and then we can check the integrity of the closure. Now, this is another thing. Actually, we know a lot of these ESD procedures are being done. Again, this is a classical example to tell you that unfit for patient is not unfit for surgery. This patient is fit for surgery. An ESD procedure was done for a large subepithelial tumor, a leiomyoma. Now, this what happens. See, then there is a tear in this. Actually, it was not possible to completely. Then we had to take this patient for an emergency thoracoscopy and complete the procedure. So it is procedures like this, actually, whenever we have this confusion, can be done in hybrid theaters as in today, which have combined endoscopy, laparoscopy facilities, so that whenever we have this problem, the patient can be changed onto the other side. So this is the procedure where the perforation occurred, and then subsequently we had to take the patient for thoracoscopy, enucleated this leiomyoma, and then close the defect that we had, and then thus saving the patient of a major post-op morbidity and mortality. You can see this on table. We have this closure, which is very, very secure. Now, whenever we have a delay that happens, especially for this Borheim syndrome, actually this patient would have this. Now, these are the patients who have this. These are the patients who cannot be treated with endoscopic suturing or clipping devices. This is a patient who failed endoscopy therapy, and you can see this thoracoscopy done 72 hours later shows extensive mucopurulent material in the pleural cavity, which is thoroughly sucked out, cleared, and subsequently we put in a fully covered esophageal stent and managed salvage this patient. For severe perforation, sometimes we may require an emergency esophagectomy, has also been reported in some centers across the globe. Now, ERCP iatrogenic perforations, Stafer has classified them as type 1, type 2, type 3, type 4. Caused by the endoscope. Type 2 is periampullary perforation. Type 3 is distal bile duct injuries related to instrumentation. Type 4 is retroperitoneal air alone. Type 2, type 3, type 4 can be managed conservatively majority of the time, but type 1 injuries are the one which require some sort of an intervention. It could be endoscopic closure or it could be surgical closure. Now, if you see this, duodenal perforation, a non-contained perforation, it's a minor perforation. It can be treated by surgery, or we have this endoscopic application options. If the perforation size is less than 1 centimeter, we have these clips available. If the size is more, we can always try this OTSC clips or clips with loop with clips actually, or you can put even a self-expandable metallic stent. Major perforation, actually SEMS is an option, but majority of these patients end up with some sort of surgical procedure like a duodenojejunectomy or a Roux-en-Y DJ or a Billrod-2 gastrectomy or a pancreatic duodenectomy also. And contained minor perforations in a stable patient can be managed conservatively. And you can see these are the surgical options that we have when failed endoscopic option. Now, this is the huge tear that happens at the actually D2 DC junction, most probably because of the scope injury. Now, these large defects which are caused by the endoscope cannot be closed by any clipping device. So these require some sort of surgical closure. And if you see the evidence, actually, only very small percentage of these patients can be treated endoscopically. Almost 50% of them require surgical closure. So you have to be very careful in choosing what type of closing device you're using, either endoscopic or surgical closing device. And if you can see this, whenever we have this these patients are taken up for surgery, their overall mortality is very, very high. So you should be very careful in choosing the type of closure. Likewise, putting in a stent, actually, this is a stent that was two double pigtail stents were put into peripancreatic fluid collection. And surprisingly, some no voice endoscopy was put in, and you can see any collection that is anterior to the stomach, you should never put in a stent. This is what happened. Actually, this stents were put into collections anterior to the stomach, and this patient had pneumoperitoneum, had to be taken up for surgery, and then subsequently salvaged. Likewise, some of these stents that are, while putting in a stent, actually the device has to be deployed very, very carefully. If you're not careful in deploying this device, sometimes the proximal branch gets deployed into the peritoneal cavity. And sometimes with the expertise available, we can extract this endoscopically, but majority of the time, these patients again may require surgery, like happened in this patient. You can see this was extracted surgically, and then subsequently we did the debridement and also removed the stent. Sometimes we have this major bleeds that happen, especially because the stent erodes the vessels in the retroperitoneum, which are very, very fragile because the edges of the thing can be very sharp and they erode the thing. And these are the things that require surgery. No sort of radiological intervention will help in this patient. This, you can see there's a big tear in one of the retroperitoneal vessels here. And then you're putting pressure here to secure the pressure to secure the vessel, and then subsequently you suture ligate this to make sure that hemostasis is acquired. So you have to be constantly follow up these patients to make sure whenever they have any of these issues, the initial bleed, the large hematoma could act as a tamponade, but the moment they try to remove this clot endoscopically, these patients have major bleed which requires some sort of surgical intervention. Like not always that these patients can be treated by simple closing device. Sometimes you may require resection like this. This is a transverse colonic perforation, actually, which resulted in resection of the colon and patient requiring an ileostomy. Now, again, a lot of expertise is required. Actually, this is one lumen opposing stent that was put into peripancreatic fluid collection. But surprisingly, it got deployed into the peritoneal cavity. You can see this is going through the mesentery of the small bowel, and you can see that actually this patient was taken up for surgery, and this self-expandable stent is being taken out through the mesentery of the thing. You can see this. And surprisingly, the bubble is spared there. That's the transverse mesocolon. You can see this. So the stent has gone literally through the stomach, through the transverse mesocolon, through the mesentery of the small bowel into the free peritoneal cavity. Then we open the lesser omentum actually, and you can see this actually. Once you open the lesser omentum, you can see that is the stent there in the transverse mesocolon coming out the transverse mesocolon, and then we extract this. Surprisingly, it has not gone through the transverse colon. It has just gone through the transverse mesocolon and the mesentery of the bowel, and then that you can see that is the stent coming out through the posterior wall of the stomach. That is the stent that is coming out through that, and then we remove this. Subsequently, we do the debridement and close this. Now, this is another device actually. You can see this that is being put in, actually deployed into for EU's gastrojejunostomy, deployed into the thing. Now, this is the thing that has been put for a gastrojejunostomy. Again, it got deployed into the free peritoneal cavity, transverse mesocolon. There's a lot of bleed. You can see this. It got deployed into and then subsequently we had to salvage and then do a gastrojejunostomy in this patient. So the overall complication, there are umpteen number of complications that occur. Actually, it is becoming a safer procedure now. Slowly, it might become a gold standard in select patients for malignant gastric outlet obstruction. But you can see that evolution that we have to have good amount of expertise and choose the patients correctly to make sure that the percentage of complications decrease over the period of time. Colonoscopy perforations are the most serious feared complication with high morbidity mortality, result from mechanical forces, barotrauma, or electrocautery, can lead to abscess formation, intra-abdominal sepsis, prolonged hospitalization, or even death. And most common site of perforation is the rectosigmoid junction or the sigmoid colon. Defects seen during diagnostic procedures have been reported to be larger than those caused by therapeutic interventions. Treatment of perforation has traditionally been surgery. Several different endoscopic clips are available. Factors that influence attempted closure of bowel preparation, fecal leakage, size of the lesion, technical feasibility, and expertise. And you can see that the successful outcome is almost varying from about 60 to 100%, depending on the size, expertise across the globe. Now, the colonic perforation surgery is indicated whenever the bowel is not prepared adequately, there is severe peritoneal contamination, large perforations, failed endoclips, deteriorating clinical condition, or presence of an underlying colonic disease requiring surgery. Laparoscopy versus open procedure depends mainly on the location of perforation and surgeon's decision or expertise. Minimally invasive laparoscopic treatment has become the preferred option and provides better outcomes than open surgical procedure. And there is a lot of data to show that laparoscopy is better than laparotomy to do these perforations. This is one example of a large tear that happened at the rectosigmoid junction. You can see this. This is a linear tear that happened actually along the linea coli. You can see this defect can be closed actually. It's a clean clean wound actually. There is no peritoneal contamination. So we can close this primarily and there is no need for a stoma. And on table, we can do an intraoperative colonoscopy and insufflate the colon to make sure that it's a watertight closure and there is no leak. And also we check for the vascularity of the bowel using indocyanine cream. Likewise, this is another major, sometimes the perforations are large because of the shearing force of the scope. You can see this tear is almost 2/3 of the circumference. This type of injury cannot be treated with any sort of endoscopic clips. This requires surgical resection, and you can see this. This is a large defect actually, and obviously this requires the resection of the bowel and anastomosis actually. So most of these things happen at the rectosigmoid junction, and these are the ones that required the resection and a regular circular stapler anastomosis to complete the restoration of the continuity of the bowel. So sometimes large perforations like this, which are caused by the scope, absolutely required resection. Likewise, of late, we see a lot of these endoscopic ESD procedures being done, especially for malignancy. The biggest problem that happens is whenever these perforations occur for ESD procedure for malignancy, it is likely that you are upstaging the malignancy because there's a lot of spillage of these contents into the peritoneal cavity. So you have to be very, very sure as to what you're doing. Actually, this patient was attempted actually, but there is a large defect here. You can see this patient again was taken up for surgery and then resection was done and anastomosis was performed. So whenever we are taking up these lesions, especially younger surgeons who are attempting EMR ESD procedures should preferably restrict themselves to the rectal lesions. Once they become expert in this, I think they should go to doing these procedures in the rest of the colon. But preferably if you're learning, I think EMR ESD procedures for colorectal, preferably restrict yourself to the rectal area so that these perforations can be managed conservatively. So you can say this complications which occur. There's the beautiful algorithms that have come that show that the perforation is less than 2 centimeters, low peritoneal contamination. These can be closed endoscopically depending on the expertise available. If the expertise is not available, you can go for laparoscopy. That's the safest procedure. And most of the surgeons are exposed to basic suturing devices. They should be able to close the defect or do an ostomy or do a colonic resection and anastomosis. So endoscopic complications are associated with high risk of morbidity and mortality. Each center should implement written policy protocol regarding the management of these complications. Recommendations are defined as position statement rather than a guideline because of the scarcity of high quality studies in these perforations. Stratification of procedures between low and high risk is important, and surgical team should be involved from the beginning whenever we're doing these procedures. The timing of diagnosis is decisive in influencing the outcomes. Failed endoscopic closure or delayed diagnosis mandate surgery. Understanding limitations of endoscopy and timely surgical intervention would decrease the overall morbidity and mortality. Laparoscopic interventions are safe, associated with better outcomes, and they're best managed by multidisciplinary approach where
Thank you, Dr. V.V. Rao. Thanks a lot for showing us the various cases in which both endoscopists as surgeons, they have to work together, and it's a teamwork, I think, and we have reached in an era where both endoscopy and laparoscopy have progressed and they are helping each other, rescuing each other. So,
Absolutely.
Any comments or questions from the audience?
So thanks and eternal grateful to you, Shatapriyo, as convener of our endoscopy board. You are our advisor every time you come up with excellent cases and all the teachings, learning from you for last 3 decades. So really on behalf of all our team, our board and everyone, and our national president is there, Govindaraj, please give you.
Thank you, Govindra.
Sir,
Thank you so much, sir.
Thank you, sir. Thank you very much, sir.
Thank you,
Since,
Govindra.
as the president, I would like to ask a question which is going to be, since AI has come into endoscopy and laparoscopy,
Yeah.
what do you think will be the role for, as surgeons we are, in the next decade? Will there be any role for a surgeon or not, as an endoscopist or not?
It's a very good question, actually. I'm a very optimistic person for artificial intelligence. And actually, after starting the department of AI in the AIG hospital, I've become more optimistic actually as seeing what is happening. And the biggest thing is actually, I think we surrounded in Hyderabad by this IT industry, which is constantly helping us, telling us what is happening. So I have seen what can be done in with a limited period of time. I mean, provided I can share some time with you, within a period of 6 months at AIG Hospital, we are able to show a lot of things which are able to, which we never dreamt of doing during our lifetime. So this has completely changed the outlook of mine actually, and I don't know whether you have seen the first ever system cholecystectomy has already been done.
Yes, sir. Yes, sir.
Yeah, so actually, I'll be talking about that basically because 15% of the work was done from Hyderabad. The system work was done in Hyderabad. Actually, validation initially, a lot of work was done from Hyderabad before they translated it into that procedure. Actually, a lot of companies were involved in that entire process. But again, that one successful procedure does not mean that we can replace the thing, but it is a caution to the surgeons that actually we have to be aware of what is going on. Radiologists, 100% they are at threat. Pathologists, they are at threat. There is no doubt about it. But surgeons, we thought we are not at threat. But basically, the way it is progressing, I'm sure that at least some basic procedures will be replaced, and I think we will require. But we have to be very, very cautious about what is happening, whether we like it or not. It is going to come into practice, partly or completely. Slowly, it will come into practice, but the amount of the chip technology, the quantum technology that is coming in, it is so amazing that actually Sundar Pichai tells us actually what can happen in 50 years will happen in the next 5 years. So with this rapid thing, actually, I'm not very sure what it's going to be, but it is going to definitely impact the way we are looking at surgery in future.
Congratulations, sir, for doing the world's first robotic cholecystectomy, which you say that is part of the AIG, sir. We are very
Partly
happy.
done. The
Partly
system
done
was
from
partly
AIG.
done.
Thank you so much, sir. Thank you.
Thank you.
And
Thank
on
you.
behalf of the EFIAGES, thank you so much, sir,
Thank you,
for
sir.
being with us.
Thank you.
Thank you very much, Dr.
Thank
G.V.
you,
Rao.
Satish. Thank you,
Have a good
Ishwar.
day.
Thank you, sir.
Bye.
Thank you so much, sir, for the wonderful session. I would now like to request our respected chairpersons to take their seats. With this, I would like to warmly welcome all the respected delegates to the inauguration ceremony for this very prestigious event, following which we'll continue our sessions. We would begin by expressing our sincere gratitude to our respected HOD, Department of General Surgery, Dr. Siva Prasad Patnaik, sir, and course coordinator, Dr. Satyapriya Desarkar, sir, for their guidance and vision in making EFIAGES possible, and to all our faculty and participants for being a part of this academic endeavor. We are honored to have such an eminent panel of faculty with us, and I am confident that this program will both be enriching and insightful for all participants. Wishing everyone a productive and engaging academic experience. With this, we'd now like to invite on the dais Chief Guest and President of FIAGES, Dr. K. Govindas, sir. Next, I would like to invite course coordinator Dr. Satyapriya Desarkar, sir. Next, I would like to invite Professor and HOD Dr. Siva Prasad Patnaik, sir. Dr. Madhuri Patnaik, ma'am. Dr. Vijay Borgaonkar, sir. Dr. Satish Mida, sir. Dr. Arka Prabhunath, sir. And Dr. I. Gopal, sir.
To mark the auspicious beginning of this academic program, we now proceed with the ceremonial lighting of the lamp ceremony. The lighting of the lamp symbolizes the dispelling of darkness and the pursuit of knowledge, wisdom, and enlightenment. I now request all our respected chairpersons and speakers on the dais to reach the lamp and light the lamp to mark the inauguration of this ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीप नमोऽस्तुते ओ दीप ब्रह्मरूप शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते
Now I would like to request HOD Professor Dr. Siva Prasad Patnaik sir to say a few words.
Respected dignitaries in the dais, dear guests, delegates, my colleagues, and dear students. It gives me immense pleasure to welcome you once again to this August gathering and this feast of academics in which we are all united and enjoying for the past 2 days. And it has been a pleasure for most of us to enjoy every session and every proceedings of the various techniques of upper GI, lower GI endoscopy, ERCP, and the other related procedures. And since it has been quite an old organization, I still remember that around 23 years back, when I went to learn laparoscopy at Delhi, at Gangaram Hospital under Dr. P.K. Chobe, the first thing I did was to become a member of the IAGS way back in 2001. So from that time, this organization is growing and the fellowship program has started and a number of people have enrolled, and we are also conducting a fellowship program here in which many people have registered. They will be appearing for exam and they will be getting the degrees. So it has been an endeavor of many of the academicians who have come all the way from Aurangabad, from Ranchi, from Calcutta, and faraway places who are joining us online, like Professor G.V. Rao and lot of other dignitaries. So it has been really a good academic feast for all of us. And I have no words to express my amount of happiness and gratitude to all of you. And I am especially very grateful to my teachers who have also joined by sparing their valuable time for this great occasion. I am especially grateful to my colleagues, my friends, and my students who worked day in and day out within a very short span of time to make this program successful. And I look forward for the success of the rest of the program. Thank you.
Thank you so much, sir. Now, I would like to request our course coordinator, Dr. Satyapriya Desarkar, sir, to address the audience.
Respected National Chair President and my very dear brother, because we started teaching endoscopy for the surgeon, now completed 3000 with Ishwar Murthy. It was not only a teaching, I think it was a mission. So we started the mission with unpredictability. We never knew that will be endorsed by the Edinburgh Royal College. We never knew that so many international places we will be called upon, and so many UK also given the honorable fellowship and others. So it was a tremendous thing which we walked through, and I feel we all enjoyed together. He is our leader now. I'm so happy that at the helm of affair he is there this year. We are definitely going to do even better within our so much limitation. I'm deeply honored and really thankful to Dr. S.P. Patnaik to give us the permission. Dr. Gopal, I didn't know him, but in the course of journey, we came so close to there. Satish, Vijay, from day one, they were with us, with our team, so that's why we went there. Orko is my junior and he is first time joining here, done a very good job. And in the last, I must say, without the delegates, without the students, and without the whole team of this gem of this hospital, we are really impressed. Their sincerity, their infrastructure, everything. It could never have been possible. And even at the last, I must say, we knew nobody, we knew only Madhuri. So Madhuri called us. Madhuri, everybody, from me to GV Rao, we came here for Madhuri with lots of really busy schedule. So you all must remember the lady behind everything, and thanks a lot, everyone.
Thank you so much, sir. It is now my honor to invite Dr. Madhuri Patnaik ma'am to address the gathering.
Thank you, ma'am. Thank you, respected and a very good afternoon, respected dignitaries on the dais, the President, Dr. Govindraj sir, IAGS President, immediate past President Satish Midha sir, Endoscopic Board Convener Dr. Satyapriya sir, Dr. Burgaonkar sir, Dr. Orco Professor Dr. Siva Patnaik, and our dear Dr. I. Gopal sir. I am truly speechless in front of all of you today with all the words of appreciations. It was conceptualized way back in February 7th when we had come from our hospital as a CME program on World Cancer Day, when Dr. I. Gopal sir, Dr. Siva Patnaik sir had given us a request that we wanted to do a national program under the IAGS banner. That was indeed a pride that people are recognizing these fellowship courses all over the country, and a place in Barampur which has been such an old medical college, and this was the first IAGS event here. So we expect more to come, and it would not have been successful with my pillars, Dr. Govindraj sir, Dr. Satyapriya sir, Dr. Ishwar Murthy sir, Dr. Satish Midha sir. They have been a strong pillar with me because myself, honestly, I do not practice endoscopy nor colonoscopy. So being with that background as a laparoscopic oncosurgeon, so to conduct this program, it was all with their support and all your support. Thank you very much, and I hope this program has been very beneficial, very helpful for your enlightening your knowledge, in-depth knowledge in this course, endoscopy, colonoscopy, and I would expect you all to even go for a higher course in the endoscopy, colonoscopy, which is the EFIAGE course. So those who want to pursue the higher learning experience and a degree and a fellowship degree, that is called FAGE, which is given by IAGS. So welcome you all, and I would also welcome you all to the National Congress next year in Delhi of IAGS, where we all will be having the convocation. So those who are the delegates for this EFIGS program, you have to join for the convocation next year. So I invite you all and hope to see you soon. And best wishes for all those who are going for the exams. Thank you, sir. Thank you.
Thank you so much, ma'am. I would now like to invite Dr. Satish Midha sir to address the audience.
Namaskar, good afternoon to all of you. Paying regards to our Lord Jagannath, dignitaries on the dais, our esteemed President, Dr. K. Govindraj, Professor and HOD, Dr. Siva Patnaik, other dignitaries, faculty members, dear delegates, ladies and gentlemen. IAGS is one of the leading organizations, not only of this country, but of one of the leading organizations of the world now, with membership touching around 16,000. And it was started none other than by father of laparoscopy in India, Dr. Tempton Udwadia. And the only aim of this organization is academics, academics, and academics. So Dr. Govindraj will give you the details of these organizations, but in last few decades, When the laparoscopic revolution started, Dr. Udwadia felt and his team felt at that time that this knowledge should percolate to the lowest level, to the remote corners of India, so that our patients are benefited from the technology which is coming. In India, not only we adopted the technology, we are innovators because Indian brains are super sharp and even Indian doctors are known throughout the world for their knowledge and skills, because you see in UK and other parts of the world, USA, many doctors, even in Middle East, people want to see Indian doctors. But we are innovators also, and many a times we are able to give better services with limited resources. So this is the beauty of Indian brain, and now India is leading in all aspects. Our economy is boosting up, our infrastructure is coming up, and in health and science, you saw Dr. G.V. Rao, that we are contributing in all fields. It's nowhere we are left behind. So I think this has been a good course. And learning is a continuous process. Learning, relearning, and unlearning. You have to keep that spirit in mind. Yesterday I was telling you that how I started learning endoscopy. When I went to Hyderabad to learn endoscopy and laparoscopy, it had just started in India. I had only few thousands of rupees. I went there for a month. I used to sleep in one of the NGO's office on the floor. I didn't go for a hotel or something. And my routine was that almost 16 to 18 hours I was working in one institute another. My day would start from 6 a.m., go to Dr. G.V. Rao, see his laparoscopy, then go to Nizam Institute, watch laparoscopy, endoscopy there, come back to, at that time Medinova was there, not AIG was not established, and it will go till 12, 1, 2 or even 3 a.m. Many a times I used to sleep there only, come back, have my bath and then start. This continued for whole of a month. I used to have at that time, I was from North India, the North Indian food was not easily available. So I used to get North Indian food only on Sundays, when I used to go to some Gujarati basa, where I used to have full thali for 35 rupees at that time. So we have to struggle to gain knowledge. So you should have a fire in yourselves that I want to learn these things. Then only you can learn and adopt newer things which are coming. And age is no bar. You can see Dr. Gorgaonkar, he's in 70s, but still he's doing his work, he's learning new things, he's introducing things, he is doing manometry and many other things which are not necessary for him, the height he has gained in his life. So that spirit must remain. So IAGS is a family. Many of you have joined recently, some of you have might. There are so many courses happening, online things are happening. So be an active part of this IAGS. Some of you will be future leaders also. IAGS is a democratic organization. People like me coming from Ranchi, Dr. Govindraj from Trichy, we are not from metropolitan cities, but with our passion and our continuous efforts in IAGS, we could become the presidents of this organization. Dr. Udwadia always said that we want people from smaller cities also to come forward and lead the organizations. So I thank whole team of this medical college, General Surgery Department. We never expected to have such a beautiful department, and they are so caring, loving. We have known each other for only last 2 days, but it appears that they have been knowing us for many years, taking our personal care, and the whole department has organized a wonderful show, so they are to be congratulated. We expect many more courses in this department.
So once again, thanking you on my behalf and on behalf of IAGS. Thank you.
Thank you so much, sir. With great pleasure, I would now like to invite Dr. Vijay Borgaonkar, sir, to enlighten our audience.
Good noon, everybody, and my respect to the dais. I would like to have only 2 minutes with the delegates. I really appreciate your zeal to take up this endoscopic procedure, and I really assure you that you now don't give it up. Often what happens, we have seen that some of the delegates, after they take this course, perhaps they may not have access to the endoscope, or they may not be practicing, and then there is a forgetfulness and they ignore it. But you will never repent in your life by learning endoscopy. We talked of artificial intelligence, and G.V. Rao also said that there is a threat to the radiologist, there is a threat to the pathologist, and he was just fumbling to say that there could be a threat to the surgeon as well. But really, I feel my experience goes nearly 45 years in this surgery. Surgeons are basically intelligent. I am also a surgeon. But the artificial intelligence, surgeons should become more intelligent in the sense that we have to gain more knowledge, and there should be an adaptiveness by everyone so that we pick up the newer procedures. When we started endoscopies in 40 years back, there was only absolute alcohol available as a sclerotherapeutic agent. I never imagined that there could be so many other applications which will be available in the endoscopies in future. But the things go on, so that you keep on learning, never give the learning process, be a student always, rather than, I like to become a student rather than a faculty anytime. And I feel that this should be one of the important aspects in anybody's life, that keep on learning newer things, and endoscopy is a wonderful tool. Please adopt it. Thank you.
Thank you so much, sir, for your enlightening words. With this, I would now like to invite Dr. Arkaprabhu sir to address the audience.
Good afternoon and thank you, delegates. I'd like to start off with heartiest thanks to the organizing committee of this college. It's a beautiful college and an awesome department. The hospitality has been so good, and you people have been so kind. I'll keep it very short. To the delegates, I'd like to tell you that endoscopy is a skill that used to be done by the surgeons but was gradually forgotten. IAGS is trying to bring it back. Please be a part of IAGS. Please be a part of this learning and this journey. It has many other courses like the hepatobiliary and the oncosurgery courses. Be a part of them. Just not the examination and the course itself. Even after the course and get the certificate, you do it in your own centers. If you have any problem, I've always found that the guides at the IAGS are very approachable, very friendly. If you have any issues, any queries, contact them and they would help you even after the completion of this certificate. Thank you. Thank you, my seniors, and thank you to all the delegates.
Thank you, sir. I would now like to invite our chief guest of today, Dr. K. Govindraj, to address the gathering.
Before I start, I would request everybody to give a standing ovation to the MKCG General Surgery Department, Dr. Patnaik, Dr. Madhuri and Dr. Gopal sir for doing this wonderful thing. Thank you very much. Thank you. Thank you. And to my surgical brethren of IAGS, my senior, the past president of IAGS, Dr. Satish Mehta. I should congratulate him because during his tenure, IAGS reached the peak. I think so far in the 3 decades of IAGS, there have been no more programs than what he has conducted. He has conducted more than 36 programs like this. He has visited nook and corner of India for that. And as Dr. Satya said that, Satya and myself, we have the last 2.5 decades with Satish and Dr. Vijay, we have been trying to teach endoscopy for all the surgeons who have joined the part of IAGS and also in the other associations also. Somehow I feel that most of the surgeons, they have left endoscopy, they have gone into laparoscopy. Now the idea of laparoscopy and endoscopy is merging art, and the people are catching up, and I can see around 40 delegates here trying to learn endoscopy. And to start with, I should say, as everybody said, endoscopy is a very beautiful art. If you learn it, you'll become so confident in doing your surgical practice, that is laparoscopy. And when I started endoscopy, as everybody says, I started in 95. I was taught by none other than, we call the father of endoscopy of India, Dr. B. Krishna Rao. Like Dr. Satish said, there are 2 stalwarts who were the basic idea for this IAGS to come to India. One is Dr. Tempton Udwadia, who started the laparoscopy. The first laparoscopy was done in India by Dr. Tempton Udwadia, and first endoscopy in India was done by Professor BKR. And these 2 people amalgamated these 2 arts and they started this IAGS. And Dr. BKR, I was the person who was trained by him in 95. When I started, after getting trained in 95, when I started in my hospital in Trichy is almost similar to Berhampur, little bigger than Berhampur, but it was also again a tier 2 city. It was very difficult to start therapeutic endoscopy. So when I started first therapeutic endoscopy, for the first 2 years, I was not able to cannulate a single time, every time I tried an ERCP. So ERCP or any therapeutic endoscopy will not come easy. Those were the days when I had to go to Germany. I was with Professor Nib Sohendra. Then I went to Amsterdam with the Academic Medical Center to learn ERCP, because ERCP was not being like what you teach here. It was not a spoon-fed like this. So we have to go there, stand as like Satish said that, toiling late nights, then only you learn this art. But now it is all, we have got simulators, not only simulators which do digital simulation, we have got simulators as natural as human beings, and we are very proud to say IAGS is the first organization, academic organization in India to acquire an academic endoscopy simulator from Japan called the Mikoto simulator. And this Mikoto simulator, it is almost 95% as in a human being. So you will be all learning this endoscopic simulator, and I wish all the people who are undergoing the exams and non-exam candidates and best wishes for this course. As Dr. Madhuri said, you all have to come to Delhi to get this convocation in Delhi. Little bit about IAGS. In IAGS, we have got various awards. IAGS has got PG Thesis Award. You can go back and tell all your postgraduates, this PG Thesis Award is 1 lakh per PG. There are 5 awards in a year. So an annual amount of 5 lakhs is being donated by GSL Medical College Rajamundry, which gives 1 lakh award for each PG thesis. So you request your PGs to write a thesis, send it to the head office of the IAGS, he or she might get this award. Apart from this, there are awards for the consultants. There is an award called the Researcher Award. There is an award called the Best Paper Award or the Best Researcher Award, Best JMAS Award. And these awards are 3 lakhs. Each is 1 lakh. There are 3 lakhs. So 3 persons will get an award in a year. So almost there are 5 awards, which is 3 lakhs in a year. That is 3 awards in a year, which is amounting to a total of 3 lakhs. So Thesis Award, then Researcher Award, JMAS Award. Apart from this, IAGS give it for 2 persons. They are all consultants who can go for a traveling fellowship, which is 1 lakh per person. You have to write to the IAGS headquarters, and if you are going to travel to any other country or within India or outside India, you will be given an amount of 1 lakh which will support your travel fellowship. You're all eligible. Being a member of IAGS, you can write to the IAGS to get these awards. Apart from this, IAGS does a lot of various courses. In endoscopy, there is the basic EFIAGES course and the fellowship advanced course called the FAGI course. In laparoscopy, you got the basic course called the EFIAGES course. And apart from this EFIAGES course, the most popular course of the fellowship in IAGS is the false hernia course and the false robotic course. These two courses are now in such a demand. They are being conducted, almost every zone has got one course. Apart from that, we have got hepatobiliary, upper GI, bariatric and robotics. We have got all these courses which are super specialty courses which are being conducted by the IAGS. So I request you all to take part. Who all have become new members of IAGS, kindly look at the IAGS website, look for the new calendar, which are the new courses. Kindly utilize these courses, and even after you undergo this training of EFIAGS, if you need to undergo some mentorship, you can write to any one of us here. We are willing to take you for a period of a minimum of 3 days to a maximum of week. You can come there, you can see how we do our cases there, both in laparoscopy and in endoscopy, and definitely you will get a guided mentorship. Whichever zone you are, you write to your nearest person who has been here or whom you know, write to them. Always IAGS members are willing to help you in take part your career, start your career in endoscopy. So with these small words, again I congratulate the Department of General Surgery of the EKCG Medical College, and thank you delegates for making this event a wonderful event. Thank you very much.
Thank you so much, sir, for your enlightening words. We'll now head towards the felicitation ceremony. With this, I cordially invite Professor and HOD Dr. Siva Prasad Patnaik sir and Dr. Satyapriya Dev Sarkar sir to felicitate our chief guest Dr. K. Govindraj sir.
I now request Dr. K. Govindraj sir to felicitate Dr. Siva Prasad Patnaik sir.
I request Dr. K. Govindraj sir and Dr. Siva Prasad Patnaik sir to felicitate our speakers, Dr. Satish Mida sir.
Dr. Vijay Borgaonkar sir.
Dr. Arka Purvanath sir.
Dr. P.K. Panigrahi sir.
Dr. K. Rajaram Mohan Rao sir.
Dr. Charan Panda, sir.
Dr. Madhuri Patnaik, ma'am.
Dr. Manoj Sethi, sir.
Dr. S.S. Mahanti, sir. Dr. Tapas Kumar Raut, sir. Dr. P.K. Gar, sir.
Dr. R.K. Sahu, sir.
Dr. Aigopal, sir. Dr. Manas Ranjan, sir. Behra, sir.
Dr. Ambuja Satpathy, ma'am.
I would now like to call our course coordinator, Dr. Satyapriya Sarkar, sir.
Last but not least, Dr. I. Gopal, sir.
Now, I would like to request Dr. Aigopal, sir, to give the vote of thanks.
So, good evening, everyone. At the very onset, I don't know from where to start thanking everyone. First of all, respected President IAGS, Dr. Govindra sir, all my speakers, dignified speakers, respectable citizens, whatever, I don't know, just don't name them, the way they responded, and they took so much of time. With the very first instance, they said us, and Of course, my head of the department, sir. Without him, nothing would have been possible. My esteemed teachers have come over here, my colleagues, and dear students and delegates. So, as Mother Madam has said, on world long cancer day, I think we had one CME over here where she was here in our department for as a speaker, and we just thought just had a seed of thought that we're going to organize a IIGS program, and then it just fermented, and suddenly one fine day we agreed that we'll be doing a course. It was very of a short span, and suddenly she told to us in April that we should do one in March. I think she told me that we'll be doing it by April, and that is the slot that is available. Without thinking further, we thought of it, and of course, our head of the department, sir, Shiv Patnaik sir, encouraged us and said us we should do a national event, because this very idea of endoscopy came to our mind, like as in the last time in the starting day I had told, endoscopy we just learned first, and probably through IAGS and of course some mentors like Prabhat Panigrai sir and all, we took the scope in our hands and we started doing endoscopy. And suddenly when we went to IAGS, we saw that this was not diagnostic, and a lot of things had to be done. And in the government setup to do it, it was very difficult. I started endoscopy at SLN Medical College, Koraput. Just started endoscopy over there for just 3 years. We started training slowly some batches. And when I came to Barampur, Professor Charan Panda sir, he took almost an initiation like, no, it has to come over to Barampur. And it took all the thing and he brought the latest scope that you're seeing now. Just 3-4 years back, he did the whole job from, and he not only ensured that we just had an endoscopy, he took the pain of bringing all the instruments starting from ERCP to CRM, everything he brought to this thing, and said that yes, surgeons has to do endoscopy. And from there, we took the charge. Of course, Sudhanshu Mandi sir was there again. Then we took the charge of developing endoscopy from that day. And suddenly, batches of postgraduates started learning it. And today, at least in my unit and many units, endoscopy is being done almost every day from Monday to Friday. And we are doing colonoscopy and endoscopy on a routine basis now. Slowly, we wanted to get into therapeutics. So then we started thinking about training them for, and this was the best platform I could have, IIGS, for training our postgraduate students from here. And with this we thought, we started everything. So thank you all very much, sir, from teachers to IIGS, especially to Madhuri madam, who probably had disturbed her for the last 1 month, probably a lot of times in trying to know actually what to do and what not to do, and she never said it. And similar to Satyapriya sir, probably even before I called, he used to call me and talk what was supposed to be done. And of course, to all my teachers and especially to Debo, Satya Swarup, Sanjeev Pradhan, a lot of students, everyone were on the backbone. Maybe I'll be forwarding someone who really did more job than what I'm supposed to say about. And of course, all my postgraduate students, including these beautiful ladies, who worked almost for the last 3 or 4 days. We had our, as sir was telling, we had our final year MBBS examination for 6 days, and everyone of them was busy over there. The day we dropped the pens over there, through the very night we started talking, doing things about over here, and everyone helped it. My special thanks to Dr. Mr. Manjit and Mohit from the event part of it. For the last 3 or 4 days, they almost helped us in every aspect of it. You should just excuse me for the small glitch that we had today, which was not in my hands actually. I tried my best not to have anything, but some way it happened. So, and of course, thanks to Olympus and Fusey, who had given us this support of stimulators and all. Hopefully, many surgeons, and we have, I have to mention this because we have a surgeon from Godaband Army College. He is in this army over here. He took the initiation that he want to have an endoscopy at Army Hospital, Godaband. This is very nearby to it. So without hesitation, he was the first guy who told that I'll be taking up the course. So he is also over here. So thank you one and all, whoever is there on the backbone and all these event guys for the last 3 or 4 days probably they almost changed everything, like starting from this, getting into this thing and all this technical aspect and all, they've done the best. We had our own cooks, Hari and all, he did, suddenly everyone agreed. It was almost like a communion that everyone just wanted to start something. Sir wanted to start something, two of them came and helped. Suddenly we saw that everyone were helping, and everything, suddenly everything helped out. Probably we'll take more in the future in a better way, and still better way from what we are having now. As sir has told, there are a lot of courses in IAGS which at least surgeons from postgraduate level should take, because we cannot be left behind from this. That is what is more interesting. Like many of my postgraduates will definitely agree, at least in my unit and all, they will agree. Many of my students, Bibu and all, were passed from here. They are doing endoscopy now outside. So a lot, Nirmala is here. He is also doing from AIMS and all. He is doing endoscopy and all. They were all, they learned from endoscopy from this place and they are doing. And more importantly, that postgraduates, now they understand that me as a surgeon, if I'm doing a surgery, it's not about just diagnosing something. If I'm getting into it, now we have NBI technology, as we have seen today, a lot of cases. Now we are able to understand at what level we should do this surgery, whether we can do or not, whether this is resectable or not. If it is resectable, how much we can do it. A lot of things are coming up into it and they're accepting it. And maybe probably slowly, as I've said, today we have seen some spellbound technologies from AAJ Hyderabad. Of course, I'm really will be very sorry if I won't mention Dr. Ishwar Murthy sir and GV Rao sir, who took up our calls and probably was there online, definitely to help at any point of time. And of course, to AAJ Hyderabad, they agreed readily. And today, they were, except for the last 7 minutes glitch, we had one of the most wonderful cases that we have seen in this total program. Thank you so much, sir, for everyone. And hopefully, we'll be doing a lot of things in the future. Thank you very much. And if I had forgotten someone, and please excuse me and be a part, and probably they will be the best persons on my back. And with these few words, I'll take goodbye from you. But beforehand, I should invite each and everyone from here, including all delegates, everyone, to join us for a gala dinner. We are hosting it again for the first time in our college garden. So we are just starting for it. Thank you very much, sir. Thank you.
Thank you so much, sir, for your kind words. Now I would request everyone to please stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
One of our students, surgeon, but still a very good dancer. So we are having a very small skit from her.
As we now continue with the program, I request my batchmate, Dr. Shweta Mahapatra, to the stage to perform this beautiful Odyssey performance.
ଶୈଳ ପ୍ରବଳ ମତ ବାରଣ ପ୍ରବଳ ମତ ବାରଣ ମୋ ଆରତ ନଳିନୀ ବନକୁ କର ଦଳନ ଆହେ ନୀଳ ଶୈଳ गजराज चिंता कल थाई घोर जलेन चक्र पेशी नक्र नासी उधारिले आपण आहे नील शैल सभा तले शुणी द्रौपदीर जणाण कोटी वस्त्र देले लज्जा कल बारण आहे नील शैल साल बेगयन जाति रे मो जवन श्रीरंगा चरण तले करुअछि जणाण आहे नील शैल
Thank you for the performance, Dr. Shweta Mahapatra. Now, I would like to invite our chairpersons of the previous session, Dr. Shiva Prasad Patnaik sir, Dr. Charan Panda sir, and Dr. Satish Mitha sir on stage. Now, I would also like to invite Dr. K. Govindraj sir on the dais to present his talk, ABC on ERCP.
That is over. Next topic. Already there. Next one. Other two topics.
Sorry.
Yeah, before I start, I should request Dr. Gopal sir, Dr. Gopal sir, Dr. Patnaik and Panda sir. As Dr. Gopal said, I request you all from the Behrampur Medical College to take much more active part in the IAGS, because so much of I very rarely see surgeons so much interested in endoscopy, that too in the government medical college. So I request you all as a president of IAGS to take active part in the IAGS to improve the art of endoscopy among the metro cities, the tier 2 cities. It should be done. Thank you. Thank you. And yeah, I think you can switch off these 2 lights. Can I have the pointer? This slide is going to be on artificial intelligence and image enhancement. Slide. Oh, it's here. Thank you. Yeah. So what is image enhanced endoscopy? What is artificial intelligence endoscopy? So introduction is despite advances in the image enhancement in the white light endoscopy, detection of early pre-malignant lesions remain a challenge. Chromoendoscopy using dyes, particularly indigo carmine, acetic acid, Lugol's iodine, which were being used for almost 2 decades now. The newer technology is image enhanced endoscopy method based on optical technologies have been introduced. So what is optical image enhanced endoscopy is, initially we used to do dye based technology. Now we are using electronic chromoendoscopy. Electronic chromoendoscopy includes NBI, narrowband imaging, eye scan. This is from Olympus. Eye scan is from Pentax, and FICE, Fujinon Intelligence Chromoendoscopy, is from Fuji. BLI, blue light imaging, and LCI, linked color imaging. These 3 are from Fujifilm. So electronic chromoendoscopy. NBI, these are the people who invented this chromoendoscopy. So I was with this person, he is Dr. Sano. Dr. Sano was the one who invented blue light imaging or white light imaging or chromoendoscopy. He is from Olympus. Whatever he invented was patented by Olympus. So they were the first people to start this chromoendoscopically, electronically. This was invented in 2005. I was training with them in 2007. And the most frequently used modality for image enhancement, and Olympus is the company which used it. The basic principle, what is the principle of image enhancement? Basic principle is the depth of the light penetration into a tissue is directly proportional to the wavelength. So there are 3 types of light here: red, green and blue. That's called the RGB. So the narrowband blue wavelength, it is 415 to plus or minus 15 nanometers, penetrates only the superficial tissue, and the green wavelength, that is 540 plus or minus 15, penetrates to the intermediate tissue, and the red penetrates to the deep tissue. Using this as a principle, this narrowband imaging was introduced. Virtual chromoendoscopy, electronic enhancement. The white light endoscopy can be changed to NBI by activating a switch in the endoscope and inserts a fixed bandwidth filter to the end of the endoscope without affecting the image quality. So narrowband imaging of the Olympus uses brune or green light 415 to 540 nanometers to highlight the superficial vessels. This enhances the vascular pattern and the pit pattern. So in this way, the classification for the polyps was, the Kudos classification was done. This application was done for adenoma versus hyperplastic differentiation, margin assessment before EMR or ESD, and detection of sessile serrated lesions were used. So this technology was used in narrowband imaging. And tissue texture and color enhancement imaging, which improves the tissue texture, which improves the brightness and improves the color. And this is useful for early malignancy detection. In eye scan, this is a software based digital processing which uses image enhancement, which was developed by Pentax. There are 3 main functions in this: surface enhancement, contrast enhancement and tone enhancement, which is done by eye scan. The surface enhancement enhances the light-dark contrast on basis of luminance intensity data for each pixel. The tone enhancement divides the images obtained by the normal white light into RGB components and converting them into newer images, useful in observing the structure of the polyp and the vascularity. This is with eye scan. So with coming to Fuji, the flexible spectral imaging color enhancement is called FICE, which is a proprietary of Fujinon and uses the wide range of spectral combination, also known as multi-band. In Olympus they called this narrow band, here Fuji calls this multi-band optical band imaging. This can produce 60 types of spectral images in visible wavelength from 400 nanometers to 700 nanometers. BLI and LCI, this is also proprietary of the Fuji. It's a type of equipment based enhancement for image enhancement which focuses on characteristic short wavelength absorption of hemoglobin at 410 nanometers. Combined with specific white light spectral colors, it results in accurate and contrast imaging. It increases the efficacy or diagnosing of very early gastric malignancies. In very early gastric malignancy, linked colored imaging is used. In very early esophageal malignancies, blue linked light imaging is used. BLI uses blue-green light. Information produces red color image enhanced process, and linked color imaging information uses all three colors red, green, blue. Unlike white light imaging, the captured image output has color enhancement in its own color range. Red changes to vivid red, white changes to clear white. Blue light imaging, intense blue light enhancement increases the microvasculature and enhance excellent for optical biopsy. What do you mean by optical biopsy? This is a targeted biopsy by using an image enhanced method. And linked color imaging or LCI increases the color contrast, best for polyp detection and enhances the red-white differences. These are the two differences between BLI and LCI. IPCL, it is called intrapapillary capillary loop. These are used in both vessel types, in schematics, in images, and definitions are and depth of information and histology. These tiny capillary loops present in the esophageal squamous epithelium best visualized using NBI in magnification. So changes in IPCL pattern helps to detect dysplasia, early esophageal squamous cell carcinoma, also helps to detect the depth of invasion. So this is the main use of intrapapillary capillary loop. The classification of Barrett's using the NBI is, we have got all the other images here, the Kansas classification, the Amsterdam classification, Nottingham classification, and Barrett's classification, blue light imaging classification. And in these, the normal how it is visualized, how intestinal metaplasia is visualized, and how dysplasia is visualized using this classification for Barrett's alone. The commonly used or in the Barrett's classification is using NBI and the blue light image using blue light imaging. These two are the commonly used methods here. The advantages are, with this overcomes the drawbacks associated with staining. What we used to do in staining use Logal's or acetic acid, and diagnostic ability is comparable to chromoendoscopy which was used earlier. In combination with magnificent endoscopy, improves the clarity and accuracy and visual assessment, particularly in colonic polyps and early gastric malignancies. It improves the adenoma detection rate, that is ADR, and it improves the detection of dysplasia also. Characterization of polyps and differentiation of invasive cancer can be done using this kind of image enhanced endoscopy. Assessing completeness of the EMR or the EST. Post EMR of EST, use this image enhanced endoscopy to know whether you have completed the EMR or EST. In inflammatory bowel disease surveillance, this image enhanced endoscopy is very useful. What is the future of image enhanced endoscopy? It improves the efficacy and diagnosis of early esophageal and gastric malignancies, assessment of pre-malignant lesions, developing useful training modules, optimization of FICE or eye scan to adapt imaging to location or structure of lesion, establishing consensus in application, image processing, image analysis based on multi-center trials. It is developed disease-specific classification systems can be brought in the future. So AI, coming to the next part of my lecture, AI in upper GI endoscopy. Introduction of AI. AI uses deep learning to assist in detection and characterization of GI lesion. Key technologies which are being used are CADI, that is computer aided detection, CADX, computer aided diagnosis, image enhanced endoscopy plus AI, NBI, BLI, LCI combined with AI improves the accuracy. So how is AI created? The first is data collection. So pre-processing happens, you have lot of data created, then data preparation happens. Validation of all these data can be used in this. Then labeling of these data and annotations can be brought. Unlabeled, you tell me, you put a black box, you label the data, you unlabel them, and training data set is done. Then learning types, there are two types of learning types in AI. Supervised learning can be done, unsupervised learning can be done, and finally evaluation, accuracy and precision and recall, which is done plus or minus 10, and cross validation happens, which is overfitting, underfitting, scalability and robustness. Finally, there is always a bias with the AI, which is amounting to today's world is around 7 to 10%, which is a bias. So there are different companies, as I said in image enhancement, different companies have different AI. Olympus calls that EndoBrain, works mainly with NBI, strong in lesion characterization, widely studied and highly validated. And Fujifilm calls it CAD-I, works with BLI and LCI as both CAD, that is detection, and CADX, diagnosis. Their strength is particularly gastric cancer detection, early color contrast integration. And Pentax calls it Discovery AI, works with iScan, which is particularly used in focusing and real-time detection. The limitation is less widespread compared to the other two. This is the Olympus system, that is the Endo-I, and this is the CAD-I from the Fuji. Here you can see the CAD-I is used for, there is a toggle which uses the simple operations like detection mode and characterization mode, and there is always a detection sound. When you are using in colonoscopy, if you miss a polyp, there is a beep there, it tells that you already missed a polyp there. And there is a detection box, you can see a box here, this is called an annotation box. If you have missed a polyp, this will tell that you have missed a polyp. Then there is a visual assist circle. At the end of the scope, there is a circle. This comes as a blue image or a yellow image, and is very user friendly. CAD-I from Fujifilm for colonic polyp detection is used in this technology. And here you can see an AI colonoscopy is being done in our center. You can see a polyp there, you can see an annotation. This is what I called an annotation. In annotation, it will say there is a polyp there, you should not miss a polyp. And if you use an AI, the AI will put a green image there. You saw a green image, it shows that whenever there is a green image, it says that it is a pre-malignant condition or a benign lesion, it is not malignant. So it helps in targeting biopsies and avoiding unwarranted biopsies. The application in esophagus is detection of Barrett's esophagus, detection of early squamous cell carcinoma. Application in stomach is early cancer detection, gastric cancer detection, and H. pylori gastritis prediction can be done using AI here. Advantages are improved detection rates, reduced missed rates, real-time assistance can happen. Limitations are false positives are there up to 3 to 7%. High cost because the image is very costly because of the equipment. Limited availability because not many centers have AI. And the future scope of AI is integration with robotic endoscopy. Better real-time histology prediction can happen. Probably next 10 years, we will have 100% AI detected to say whether it is malignant or not. So you will have a tissue diagnosis before you even take a tissue itself. The conclusion of AI is transforming diagnostic accuracy and standardization in upper GI endoscopy. So AI with AI image enhancement will revolutionize the way in which image enhancement is happening and in the way you are detecting endoscopy. Thank you very much. If there are any doubts, I can tell on whatever it is happening in today's world in AI, in image enhancement and in AI. Thank you very much.
Thank you, sir, for a wonderful lecture. And regarding the AI enhanced endoscopy, I think it has increased the accuracy as well as the competency of the endoscopist in detecting. And the one good thing about endoscopy is that, as we already knew from our childhood days, prevention is better than cure. So the preventing part is really very well developed so far as the AI is boosting up the efficacy of the endoscopy. As you told, the blue light and white light imaging, as well as the AI and the narrowband imaging techniques which have been incorporated. So the earliest and the things which were not properly diagnosed by our light endoscopy, they are being detected. So that is the biggest advantage. So what is there more store in the future for endoscopy?
Community screening can happen. As you know, in the West, where colonic cancer is very high, they started colonoscopy screening for people who have got in their family polyposis or any other family with a colonic malignancy. They start colonoscopy screening around 40 years of age. In that way, you do an early pickup of the lesions. The treatment is more, and the treatment, the survival rate has been increased. In colonic cancer in India, the survival rate is only 40%, compared to the West is 90%. So in that way, we started in our center an early detection bus called the EndoBus. And in this EndoBus, I got the AI system of endoscopy. My team goes to villages. We do upper GI screening and we do colonoscopy screening also. In the last 2 decades since we started the EndoBus, we have done around 800 cases of upper GI screening, in which we have detected 3 lesions. One in the esophagus, one in the stomach, one in the postcricoid region. And these patients would not have come to us in an early stage. We detected them in the early stage, we are able to treat them. In that same way, our colonoscopy pickup rate is still very low, because people willing for colonoscopy is very less. Even though we do it free of cost, the colonoscopy procedure has to be done in a nearby associate primary health center, because colonoscopy sometimes needs sedation. The complications of colonoscopy is there. It's not as easy as an upper GI endoscopy.
Yes.
Upper GI endoscopy, we go to remote areas, tribal areas. We have gone to very many tribal areas. We have done upper GI endoscopy in the tribal areas. If not for our bus to reach there, for a people from a tribal area to get to an endoscopy center, they have to travel minimum of 3 to 4 hours, spending around 5,000 to 6,000 rupees. So in that way, we can do community screening of upper GI endoscopy to pick up lesions early, where AI is found very useful.
Yes.
No. That's what I told you initially. Colonoscopy, we do screening for people who have got in their family some kind of a colonic malignancy which has happened, or colonic symptoms they have, IBD, IBS symptoms. Then we do them a colonoscopy, not for screening for everybody. For screening for everybody for 1.4 billion, it's not easy.
Actually, the Japanese have shown the path to the world, that by routine use of upper GI endoscopy, not only they have detected the gastric cancer at the earliest phase, but they have used upper GI endoscopy as a therapeutic method also. Because the early gastric cancer, they have been managing by endoscopy only.
Yeah.
So that is the biggest contribution of endoscopy for the treatment and prevention of upper GI malignancy.
If you look at the Japanese people, because I have been many times to Japan for my training, for an average time taken for an upper GI endoscopy for one person is 45 minutes. Can you imagine doing 45 minutes for one endoscopy in any government setup?
No.
So practical reasons are there. So they do a thing called mapping of an upper GI endoscopy. So they map the upper GI endoscopy. For a normal endoscopy, which we call as a normal endoscopy, they take at least 30 to 40 biopsies. We would do an endoscopy for 5 to 10 minutes for an upper GI endoscopy.
Right, right.
And for if it looks normal, you will not take even a single biopsy. Even for a normal upper GI endoscopy, where they do AI, they do this image enhancement, they take a minimum of 30 to 40 upper GI biopsies, and they have got a map from which area they have taken. And so they are able to detect malignancies in the gastric cancers before we could even imagine. So that is the reason they are able to treat gastric malignancies by endoscopy itself.
Yes.
Because there the incidence of gastric carcinoma is high.
Very high, very high.
So it's not indicated in our populations also, sir. But earlier they used to have stage 3-4 lesions, but now...
No, after their screening has started in the last 30 years, they get only stage 1 or stage 2 only. And their modality of surgery also, even for a very early malignancy, they do radical surgeries. So the survival rate in the world for gastric cancer is Japan only. The survival rate of gastric cancer in Japan, for 10-year survival rate, they have got more than 60%. That's what. 10-year survival rate is more than 60 to 70% there.
Even for all malignancies, they believe in radical surgeries. Means some of the things which others will not do, they will para-aortic and all, they will dissect.
Yeah, and they got this mapping, what I say, they got the data of each individual endoscopy done in the last 10 years. Unimaginable. But
not population. They are very meticulous.
Very meticulous.
Very meticulous, methodical, and committed to their job.
Dedicated people are there. Some people, they are focused also.
Yes.
One person is doing one thing only. So here we do so many.
And when they look at us, keeping 5 or 6 cases of gastric cancer in a single day in the OT, they were surprised to find us in our cancer institute, that they tell that we do only 1 case per day, because they will spend the entire day, say 8 to 10 hours, for detecting each and every lymph node station and making it a separate leveling and biopsy and doing a real D2 or D3 resection.
And the same
Which
surgeon,
we are compromising
the same surgeon will give the chemotherapy also there.
Yes.
Here it is a different way. Japan is a total different way. But few things you learn from Japan is, after my many visits, is early detection cures it. So for early detection, you should have mass screening. Whatever we can do for the society for mass screening, I have started a bus that was started in memory of my father. It is called Dr. Kanagaraj Gastro Foundation. It's called KGF Endobus. The last 2 years I have been visiting mostly tribal areas doing upper GI endoscopy, screening endoscopy free of cost.
About Japan, I am fascinated with the discipline, honesty, cleanliness, everything they have. Thank you, sir.
Thank you. Thank you very much.
For a wonderful lecture.
Such a distance place and shared your knowledge. Thank you, sir.
Some water. No, you have to get a new system.
You have got different software.
That's a new system. It's a software. Blue light imaging is BLI. Linked color imaging is LCI. You need a software processor. In those only you can do that. Yeah, thank you. Next one. Yeah, I'm the speaker. Yeah, okay.
Thank you, sir, for your insights on topic AI and image enhancement endoscopy. I would now like to request chairpersons on the dais to take their seats in audience. For the next session, I would like to invite, it is a privilege to introduce our next distinguished chairperson, Dr. P.K. Kar. Sir currently serves as the President of ASI for 2025, a testament to his leadership and immense contribution to to the surgical community. He has previously held the important position of CDMO of Ganjam, reflecting his dedication to public health and administration. A highly experienced senior surgeon, he brings with him extensive expertise in both general and laparoscopic surgery and has been instrumental in advancing surgical care in the region. We are truly honored to have him with us today and request your presence on the dais.
It is now my great pleasure to introduce our next chairperson, Dr. Arka Prabhunath sir. He completed his MBBS and MS in General Surgery from the West Bengal University of Health Sciences. He is currently practicing at ISKA Sanjeevani Hospital, Baranagar and Kharda, where he specializes in both general and laparoscopic surgical procedures. His expertise spans diagnostic and interventional laparoscopy, along with endoscopy and colonoscopy, reflecting his comprehensive approach to modern surgical care. We are delighted to have him with us today. May I now invite him to grace the stage as the chairperson for the next session.
Now, it is my pleasure to introduce our next chairperson, Dr. Tapas Kumar Raut sir. He completed his MBBS and MS in General Surgery from SCP Medical College and further earned his EFIAGES qualification from IAGS in 2016. He was previously an associate professor at MKCG Medical College. With his strong academic background and clinical experience, we are delighted to have him with us to chair the next session. With this, now I would again like to invite Dr. K. Govindraj sir to present his talk.
Yeah. My third topic today is role of endoscopy in GERD and achalasia. And the three parts in which it helps in achalasia is in diagnosis, in endotherapy, and during laparoscopy. Definitely endoscopy is also useful. And if you look at these images, endoscopy findings in achalasia, you have food and fluid filled esophagus. Esophagus is usually a large cavity you can see here. Sometimes you will mistake it for a stomach also. And this kind of a dilated esophagus is there. There will be no peristalsis here. There will be spasticity in the lower esophageal sphincter will be seen. And this is the investigation of choice to diagnose achalasia cardia, because previously we all used to do one barium swallow study. Barium swallow study can be done even today, but this is the choice, esophageal manometry. So esophageal manometry device we use here, that is to find out whether it's a type 1, type 2 or type 3. So what is the endotherapy for achalasia we can do? For almost 3 decades we have been using pneumatic balloon dilation, and Botox injection came later, and now the newest entry into this is called the POEM. What is POEM? It is per oral endoscopic myotomy. So now I am talking about the balloon dilation here. You can see here, this is a dilated esophagus here. At the lower esophageal junction you have a spastic esophageal sphincter, and you can see a classic barium swallow here you can see. And this is the device which you use here. This is called the Rigiflex pneumatic dilator. Rigiflex pneumatic dilator. And this is a CRE balloon which is used for dilation for both benign and strictures. This is a CRE balloon. This is a Rigiflex dilator. For this Rigiflex dilator, you have to use a pump for that. You have to maintain the pressure at 9 atoms. 9 atoms you have to maintain the pressure for a minimum period of 45 seconds to 1 minute. So this is the lower esophageal sphincter here you can see there, which is very spastic, and once the dilatation is done using a Rigiflex balloon, you can see the spastic balloon dilatation rips off the lower esophageal sphincters there, the musculature is getting ripped off, and then once the ripping off the musculature is done, then you have a nice dilated lower esophageal sphincter. You can see there, nice dilated lower esophageal sphincter is seen there. And next comes the poem. What are the disadvantages of balloon? I will tell later. Then the poem requirements are, you need a nice high definition video endoscopy, good diathermy unit tissues will be there, hybrid knife, this is called a hybrid knife, and lower pressure carbon dioxide insufflation is required, insufflator is used, irrigation pump should be used, and it should be done under an OT, under GA it should be done. And the scope tip, you should have a scope tip cover is there. You need a high definition endoscope. This is a carbon dioxide insufflator. You need instruments like this RB, what they were using in AIG there. To use this kind of instrument, to use a poem there. Per oral endoscopic myotomy is done. The procedure involves the following steps. Mucosal incision is done. You do a mucosal incision. This is mucosal incision is done. You get into the submucosal space there. This is the submucosal space here. And then you do a submucosal tunneling. From here, after doing an incision, you do a submucosal tunneling. You come to the lower esophageal sphincter area. You come to the lower esophageal sphincter area. Then you do a myotomy there. There you do the myotomy. You do the myotomy. You start doing the myotomy from here. You extend it up to the lower esophageal sphincter area. And the myotomy is increased from the lower esophageal sphincter area at least 3 to 5 centimeter into the gastric area. You have to increase it. Then closure of the mucosal incision is done. This is the area where you done the mucosal tunneling. You have to close this area using clips there. This is the mucosal tunnel. This is the poem which we do there. You have to create this is at least 15 centimeter proximal to the lower esophageal sphincter. Here you do a mucosal entry there. You enter into the submucosal space. Here I am using a hybrid knife here. I create a submucosal path, and then see I am infiltrating with saline, with this infiltrated with methylene blue. I am creating a tunnel there. I am creating a space there. Once I enter into the submucosal part, I create a tunnel. I go up to the lower esophageal sphincter. Then once I create a tunnel, then I come back to the area where I have done this mucosal tunneling. I again do a myotomy from this area and then increase the myotomy. Now this is the tunneling which I am doing here. Once I completed the tunneling, I do a myotomy. I complete the myotomy up to the gastric area. At least 5 centimeter into the gastric space, I need to do this tunneling. See here, this is the mucosal area. This is the mucosal part, and this is the muscular part. I am completing the tunneling here. Then I do the myotomy part. Once I complete the myotomy part up to the gastric area, I make sure that there is no mucosal rent there. The mucosa should not there should not be a rent in the mucosa. If there is a mucosal rent there, I have to close it with the clips there. This is how we use endoscopy in lap Hellers. Here I am doing a laparoscopic Hellers myotomy. When I complete the laparoscopic Hellers, I come to the esophagus part and I need to see there the mucosa there. Now I ask my assistant to do an endoscopy there. You can see there when I am doing my assistant doing an endoscopy, I have cut all the muscle fibers here in the lower esophagus and in the stomach also. And you can see that shining light of the endoscopy coming into the lower esophageal area. See, I am completing the resection of all the lower esophageal muscles there. You can see the thick muscle there. Here the trick is I use the harmonic, reverse it and use the harmonic here so that the shearing doesn't cause any perforation of the mucosal lower esophageal mucosa. You can see there, you can see the shining light of the endoscope there. In this way, you can make sure that there is no rent in the esophageal mucosa. See, I am reversing the harmonic there and using the shearing method to the reverse side. And once that is done, I have completely released all the thick muscles of the esophagus and the lower esophagus. This I extend to at least 10 centimeter proximally, then do a closure of the crura here. The crural closure is being done. So in comparison, the type of the procedure is balloon dilation, lap Hellers and poem. The type of least invasive is the balloon, the most invasive is the lap Hellers, less invasive is the POEM. Ease of the procedure, balloon dilation is very easy, lap Hellers is easy to master, and POEM, the steep learning curve is there. Effectiveness, the balloon is very short-term effectiveness, and effectiveness in lap Hellers is long-term, and POEM is also long-term, because POEM results are awaited for more than 15 years, and incidence of reflex in balloon dilation, significant reflex is there. In lap Hellers, less, because you always combine a lap Hellers with the anti-reflex procedure. You do one DOR procedure to do an anti-reflex procedure, and in POEM it's a matter of debate. But now in POEM, anti-reflex procedures have started. So recent advances in POEM is POEM with anti-reflex procedure. This is called the POEM with the anti-reflex procedure. You can see there a POEM is being done. Once the POEM is completed, you make a rent in the gastric mucosa and gastric muscularis layer and gastric serosa are entered into the peritoneum. You do an anti-reflex procedure using an endoscope. See, using an endoscope, you can do this anti-reflex procedure also. This POEM anti-reflex procedure was advocated by Dr. Amul Bapai from Pune. He is the one who started this procedure worldwide, and he has done around more than 250 cases of this anti-reflex. He has published this recent result which says that this POEM anti-reflex procedure result is compared to the lap Hellers anti-reflex procedure. So he is the only person in India who has done such a vast study on POEM anti-reflex procedures. So POEM is an accepted procedure for achalasia cardia. Post-POEM reflex is common after the procedure. POEM endoscopic fundoplication, that is POEM, FPOEM, to prevent post-POEM gastroesophageal reflux is an evolving procedure. There are only few centers which do this procedure. Achalasia related motility disorder, POEM, the myotomy is done, which has got a refractory gastroesophageal reflux. POEM plus, that is an FPOEM, the reflex is reduced. So this procedure will come to stay probably another few years of time. So GERD, indications of GERD in endoscopy is endoscopic grading of esophagitis, investigation for GERD prior to surgery, endoscopy finding in various types of hiatus hernia, endotherapy for GERD, endoscopy after fundoplication. So GERD, normal anti-reflex mechanism in human is lower esophageal sphincter, that is the basal lower esophageal pressure, Pinchcock action, here the Pinchcock action of the diaphragmatic crura, angle of his, here at the angle of his, gastroesophageal flap wall, all these are in this area, posterior lateral localization of the fundus, this fundus posterior lateral localization, and esophageal motility. These all are the important things which create an important bandwidth in GERD treatment. And so GERD treatment, altered mechanism at the OG junction, which is normal crural sphincter reduces the lower esophageal sphincter spasm and the pressure, absent angle of His, you can see there is no angle of His at all. Here wide open crura, the crura is wide open, the sphincter of and the normal lower esophageal pressure is lost. There is absent of angle of His, an angle of the altered position of fundus. The fundus itself goes into the beyond the diaphragm. So these two mechanisms should be corrected in an GERD when you treat the symptoms. Typical symptoms are heartburn, atypical symptoms are atypical chest pain, laryngitis, upper reflex incidence, dental plaque and oral ulcers. Alarming symptoms are dysphagia and GI bleed. The investigation which we use for GERD are barium swallow, endoscopy, 24-hour pH monitor. This is the important investigation which we use. Next comes manometry, in particularly impedance manometry is being used. This is the 24 hours impedance manometry which we use in our center. The scoring system is the modified Demister scoring system which we use here. Dysphagia, we score is 0 for none and for 3 for impaction and difficulty in swallowing. For heartburn, 0 is none and for 3 is interference with daily activities, and for regurgitation 0 is none and third is interference with daily activities. This scoring system which we use, which we do for a 24-hour pH monitoring, and the Savory-Millard grades or the Los Angeles classification. These two classifications are commonly used in the endoscopy. Commonly used is the Los Angeles classification for endoscopy. Grade A is only very narrow band is there, and there is between two, there is a high sign of erosion is seen. Grade B, there is more than 5 centimeter, and grade C, when there is more than 5 centimeter, 3 columns are there which are not connected, and grade D is more than 3 columns are there and which are interconnected. This is the Los Angeles classification which we use. And endotherapy for GRD is lower esophageal sphincter augmentation and remodeling of the gastric flap valve. So what are the procedures which are being done? Strata device, which is the radio frequency device which is used for lower esophageal sphincter augmentation, is being done, and remodeling of the G flap valve. Here TIF, ESOFIX device by the endogastric solutions, Muse endoscopic stapling device, that is by Medigas. ARMS procedure of endoscopic anti-reflex mucosectomy is done, or ARMA, which is an anti-reflex mucosal ablation, can be done, and endoscopic full thickness plication or GERD-X can be done. These are the endoscopic procedures which we can use for GRD. Strata is being done as an early stage for reducing the lower esophageal sphincter. The reflex, the weak muscle, there is always a reflex there. If we use this, the strata therapy, where the device is being used here, I'll show you an animated image here. This is an animated image of strata being done. You use this device at the lower esophageal 5 centimeter, you can use this device. You can use this from 5 centimeter up to 10 centimeter for various levels you do. Post procedure, this increases the muscular layer thickening is being increased, and thereby increasing the pressure at that level. So it reduces the reflex that happens. So in this way, strata is used for reducing the anti-reflex. See, the muscle becomes thickened, so the reflex that happens post procedure is reduced. This is strata which is being reused. Transoral incisionless fundoplication is called TIF. Here what happens is, at 11 o'clock position, you take a bite there, and then you rotate the endoscope there, and then ESOFIX is being done here. So a kind of an you do a laparoscopic HLS, which is being done without doing a laparoscopy, which is by a device called ESOFIX. You can create a flap valve, like you can see an endoscopy. From a laparoscopy, you can see the endoscopic ESOFIX being done. A laparoscopy has been introduced, but an endoscopic device has been done. You are creating a flap valve here, and this is the procedure called it ESOFIX. Next comes the GERD-X. Here you use a full thickness procedure, where you are reducing, you are going and catching the mucosa there. You pull the mucosa into the endoscope, and then you do a stapling is being done. Once the stapling is being done, you rearrange the flap valve at the lower esophagus. Then you need to do at least 1 or 2 flap valves, staplers should be done. So this stapler once applied, you are reducing the narrowing of you are increasing the narrowing of the lower esophageal sphincter, and then you create a flap valve there, you increase the pressure there, thereby reducing the reflex in that area. So this is the GERD-X. Now comes the anti-reflex mucosectomy, which is called the ARMS procedure. Here you create here see, you can see there, we are creating a band. You are using a band, you are creating multiple bands in this area at the lower esophageal layer, from you are doing by a J maneuver. And once you have done these bands, then do a mucosectomy using a snare technique. Once you have done a snare technique, the entire mucosa, you don't do more than 2/3 of the width of the esophagus. This is the mucosectomy which has been done. Once you inject the submucosal layer with saline with methylene blue, once the mucosectomy has been done, you can see this submucosal layer here. For the 2/3 of layer, it involves hemicircumference mucosa for the EMR of the cardia. Mechanism is surgically created mucosal heals and tissue contraction happens, narrowing the lower esophageal sphincter. This is called the ARMA. Next procedure is called the ARMA. What is ARMA? You do an anti-reflex mucosal ablation. The device which I use here is called the APC. So using a J maneuver, I do multiple layers of APC, 2/3 the layer, and this 2/3 layer, 2-3 layers I do, and once I do this ARMA, this results happen at a maximum of 8 weeks. So this results of ARMA to happen is 8 weeks, and you have to study after 8 weeks, then study at the level of 1 year, you do one 24-hour pH to check how the ARMA has been effective. The complications of GRD are esophagitis, stricture, Barrett's esophagus, adenocarcinoma. The last two are the most important thing why we do these procedures. This is a Barrett's esophagus. The Barrett's esophagus is seen at the lower end. You take a biopsy to prove that it's Barrett's esophagus. So I am doing an EMR here. See, you can see there are two images here. See, I am doing a banding. As you would see in a variceal ligation, I am doing a banding of this EMR. Once I have proved there, then I am doing a banding here. Once I have done the banding there, I am doing a snaring and removing of the EMR. I am doing the EMR there. Other treatment for Barrett's are EMR, heater probes, APC, radiofrequency ablation, and laser can be done. Cold probes, cryoprobes can be used. Photodynamic therapy or carbon dioxide laser can also be used. But the best procedure is the EMR for this Barrett's esophagus. To conclude, in achalasia, endoscopy versus surgery has equal results. In GRD, endoscopy versus surgery, the results are debatable. So, in the evolving era of endoscopic treated GRD, and still there is very debatable. So, I would say you still have to go for at least for few years till surgery and endoscopy become equal for GRD or achalasia. Thank you very much.
Thank you, sir. Thank you for depicting the videos so nicely and for elaborating the treatment side. Thank you so much. But as you said, it will take a longer time, some more time to equal with the surgeon's surgery part. Anyway, let's hope that through endoscopy we can do it, and that will be a good thing for us. Thank you. Thank you so much, sir.
Thank you, sir. Thank you.
Sir, for achalasia, instead of balloon dilators, can we use that traditional dilators, that is the savory?
No.
We cannot.
No. See, that's what I said. Here the pressure is so much, and the radial force you require to do is 9 atoms. And you have to keep in the 9 atoms. Only the Rigiflex balloon will give that 9 atoms. Savory Gillard will not give that 9 atoms. Will give hardly to 2-3 atoms of pressure, and it's a graduated. It will never break that. So you have to use Rigiflex balloon to dilate it. No, you can use it for strictures.
Sir, an EMR for GRD, only resecting the mucosa will solve the GRD?
Yes. So you have to have a manometry. You have to do a classification of the reflex, and you have to do the classification of the with the manometry also. In that case, where the GRD reflex after the 24-hour pH monitoring with impedance, which only grade 1 and grade 2, but the patient symptom is high, you can use ARMA or ARMS procedure, that is mucosectomy or mucosal ablation can be done. It is debatable for grade 3 also, but grade 4, I would request you only do an Heller's myotomy, Heller's laparoscopic Heller's fundoplication, or you have to do a poem.
Thank you, sir. Thank you.
Thank you. Thank you very much.
Thank you so much, sir. With this, I would request the chairpersons to resume to their seats. Now, with this, we come to the end of today's session, that is day 2. I would now like to take this opportunity to invite everyone to today's gala dinner at MKCG Medical College Garden, which will be hosted at 7:30 p.m. Thank you so much.